muscles and all that kind of jazz. So you missed my joke, Chris. You didn't.
I don't think people are going to miss that. I'm not going to lie. No, don't think they are.
I would actually like that 30 seconds of my life back if I could.
No, you signed up for this course. You paid for this course. That's what you get. Okay, that's included. So corresponds to each different level of the skin, and it kind of goes by degrees. Makes it simple, right? So if it's a first degree burn, it's only affecting that top layer, so that epidermis, right? Usually it's going to present with just some redness, some tenderness, and it's just kind of, right? It's a sunburn. Everybody's had a sunburn before. Just kind of annoying after a while, right? It's just the skin has that kind of really painful itchiness to it, but not so much of a life threat. And the reason is because it's got this minimal blistering, it doesn't really get through that top layer, open up the skin for infection risk. And it's usually not severe enough where the body's going to have to make huge system-wide adjustments for its temperature. But this is also like for people who have had really bad sunburns, right? You feel extra hot and extra cold all at the same time. It's just as kind of a symptom showing you that your skin is having difficulty kind of assessing what the temperature is. So then when it gets to that second degree burn, that's when it would be past the epidermis, affecting through that top layer and down into the dermis. This is usually caused, and you can assess this by seeing what we call blebs or blisters. So they're going to be really kind of big blisters, yellowish in color. And it's just pretty obvious that the skin has been very much so burned. And these are incredibly painful. It's actually second degree is much more painful than a third degree burn. And as I talk about it now, I'll explain why. So anything past that second degree is when we start to get way down into the tissue of our body. So past the skin down to muscle. Now, third degree is really anything that gets past that subcutaneous tissue or to that subcutaneous tissue, because then it can affect the muscle and even, get down to the bone. It usually is evident by signs of like charring and black, like roasted skin, essentially. And so one of the reasons why this is actually more painful than a second degree is actually more painful than a third degree is that for the most part, when a third degree gets down to its extent, it has burned away the nerve endings. So the center of the burn where the heat was the strongest is actually burned away, any possibility for the body to feel it. So what the patient is actually feeling is the pain from the second degree burns that kind of emanate around it. So that's another thing we see is that if there is a really strong burn, we tend to see rings of diminishing burns as it goes out. So there's kind of like a focal point of a really strong third degree burn surrounded by second degree, surrounded by first degree. That's just kind of how the heat disperses, right? So up here, just kind of an instance of a mild to severe first degree, right? We do have a little bit of a blister there forming, but for the most part, they're going to be irritated. It might hurt for a bit. It's going to be awful on their hands. Eventually, they're probably going to start peeling. But besides that, for our treatment wise, hey, rub some aloe on it, get ready for kind of an annoying couple days. Besides that, there's not much we can do. Down to second degree, which you can see is classified by those blebs, those big painful blisters. And as I showed you guys, that's me. I just realized this, I'm wearing that same shirt. That worked out well. So I got second degree burns. That was from the sun. I just was not wearing enough sunscreen. I was out on the lake, just kind of forgot to do it. Woke up the next morning, had the worst burns of my life. Probably the worst pain I've ever had too. Really bad. So try not to get second degree burns. Wolf Mother is a band. It was one of my favorite bands for a long time. And so yeah, really painful. Took a long time to heal. Now I always wear sunscreen on my shoulders, but for the most part, you can see that it's really classified by, we've got the blebs, those blisters. You can even see the first degree burns around where it was. So the sun directly on my shoulders was dispersed and it ended up burning right there. So our treatment of these, we actually want to leave them closed. We don't want to pop them because then we'd be opening up the skin to potential infection. And when we move on to our third degree, you can see that classified like that charred skin. It's gotten way down past that top layer, pretty much just the subcutaneous tissue. I don't see any bone here, so that's actually good, right? It's just skin burned, not muscle yet. But you can see that the heat was very strong on this person's legs, and you can see where some of that stuff has come off, right? And surrounding these really charred burn areas, you can see different levels of severe burns. So our first step is going to be really assessing how severe we think the burns are. A report of a burn, right, can be anywhere from somebody engulfed in flames to somebody who touched their hand pretty quickly to like a hot stove or something like that, right? So while there might be a 3rd degree burn, if it's really small and from an accident or something like that, we're going to have to determine really what's going on. So the things that we're worried about is what caused the burn, right? Is it something that could cause me a burn too? Is there a house fire? Is there an open electrical thing going on? Is an electrical wire down and actively sparking? Is there a chemical in the air, right? Those things we're going to have to consider. And depending on what it is, right, we're going to have to determine what we do. We also want to know how deep the burn is. We want to get a rough idea if it's 1st, 2nd, or 3rd. 1st degree and mild 2nd degree, don't be super alarmed, right? But anything that's a 3rd degree, we definitely want to take care of that pretty quickly. Not with the worry that the patient is going to succumb to that burn right then and there, but the longer we have that wound untreated in an unsterile environment, the faster or the higher the potential of them getting a really bad infection are. What's the extent of the burn? So not necessarily just how deep did it go into the body or to the skin, but across how much of the body is it covering, right? If it's just a hand, that's a little bit different than an entire arm or a torso. Are there any critical areas involved? For a burn, what would we say that a critical area would be?
Face, for airway.
Yeah, that's pretty much it. That's exactly it, right? Places that if they are not able to breathe, that's really bad. So burns to the airway are incredibly dangerous, hard for us to treat. It can cause irritation to even like damage and swelling and bleeding inside the airway. That's not good, right? So if it's a burn to the face or the airway, that makes our patient way more severe than if it was just a burn to the arm. We also want to check the age of the patient. Are they younger than 5 years old or older than 55? That's just that range of when burns become far more severe for the patient. Less than 5 years old, they are small, so burns tend to cover more of them, which can lead more of their body, which can lead to a longer recovery time and more risk of mortality. And then when you have reached a certain age, your ability to manage injuries like this diminish. So that would make it a more severe patient. Similar to like trauma, if a person who's older than 65 falls from a standing height, that's a high priority patient or a high mechanism of injury. Same thing with burns. If somebody's older or younger, that's going to make us a little bit more cautious about actually how they're doing. They're likely going to decline faster. So when it comes to depth, right, shallow burns can range up to 2nd degree, but they're really only affecting that top layer. So my 2nd degree burns were shallow because they really were just down to that through that epidermis. That's why you're getting those blebs. It's because it's coming through that damaged kind of that tissue. It's spawning that fluid and it swells up from where it is. And then same thing with those 1st degree, right? It's only affecting those top layers. So while it can be painful and dangerous, right, it's not getting down to any of those really internal structures, down to the muscles. So we're going to have to be a little bit less worried. We still want to leave those blebs intact. The burnt skin underneath is it's unable to protect itself, essentially. It's unable to defend against infections, and it gets infected really quickly. So we want to make sure that we're leaving as much of the skin intact as possible. Now, again, disclaimer here, I probably should have done this a little bit earlier. There are some pictures in here, specifically the next slide, of severe burns. So if we get down to deep burns, right, it's down past the skin, and it gets right to the muscles, essentially burning away the entire protectant that we have on our body. So when that happens, right, the entire connection to the outside world is essentially lost. We'd still have sensation, but very diminished and inaccurate from just that. You're also just going to not be able to manage your own temperature. So that section of the body is completely unable to keep its own heat in. So it's just losing heat constantly, which is a big deal for us. We need to be kept warm, especially in instances of severe injury, right? So You see that, you can definitely say, wow, that's a deep burn, really bad. We need to get them going to the hospital as soon as we can. But one of those other questions that we need to ask is, how extensive is the burn, right? We've got the depth. It's a bad one. I can see muscle, but what's the extent on their body? So this is when we discuss using something called the rule of nines, which is just a kind of abbreviated way for us to give a rough estimate to the hospital of how much percentage of somebody's body is covered by burns. So if we were looking at those first two pictures, right, it's pretty much just one of the legs from what we could see. That really gross one on the right, that was, I think, both front and back of the leg, right? So that'd be roughly 18% of that person's body burned. So we could just use this, be like, hey, 18% their right leg, front and back, severely burned down to the muscle, right? We need to get them in immediately. And they'll register, wow, that's bad. Again, similar to like GC, Glasgow Coma Scale, they might ask you what percentage of the patient's body is burned, but that's really on extensive burns. And if you think about it, right, there are plenty of times where just somebody's hand might be burned, or it's going to be a severe burn in a small area. And if it's like a really bad specific area burn, you're not really going to have a way to accurately tell them what percentage. And if you accurately describe, it's a roughly an inch section on their forearm, 3rd degree burn, that's pretty much good enough. The smallest assessment or the estimate that we can do with burn percentage is something called the palm rule of hand, essentially. And if you take the patient's palm, the size of this piece of skin without the fingers included, just their palm, that's roughly 1% of their body. So if you take a look at their palm and you estimate, okay, 1, 2, okay, sure, 2% of that person's body is covered in burns if somebody asks you for a percentile. With kids, same-ish rule, right? We do have to change some of the math down here for the legs, but it's a rule of nines, multiples of nines, and this can be kind of tricky remembering all of it, but if you just remember that it gets to either 9 or double that, you're good. So this is one of those things, keep this in your head. Besides that, palm rule is pretty good, right? It's very rare instances that we're going to go to somebody who's covered in burns. And when you do, you're going to say, wow, their entire torso, that's 9 plus 9, 18% of their body. Now, when it comes to kids, right, similar to what we were saying about how if they're younger than 5, the burns are going to be more severe due to how big they are. But it's also, they just have more surface area relative to adults. So a 2% burn on an adult would likely be way more than that on a kid. And that means higher the surface area burns, more potential for it to be in a super serious area like their airway, or just cover enough of their body where their ability to regulate their temperature, to fight off infection, all of that is going to be so diminished that they have a very slim chance. With kids, the other thing that we want to consider is that many burns can result from abuse, right? Kids, while they do oftentimes burn themselves by accident, right? My dad told me the stories and showed me the home videos of the wood stove we had in my first home that I just wanted to go run and touch because I just liked the flashing lights. I apparently thought it looked cool. I was like 1 year old, right? So he tells me the story of all the time how he had to get a custom fence made from a person that would hold back a kid, and he just wanted to let me touch it so I wouldn't do it again. So plenty of times kids do that, right? They reach up, they grab something off the stove, hot water falls on them or it gets on their arms. They touch something that's really hot, they fall down or something like that, right? So what we can consider here is the patterns of abuse versus patterns of accident. So this is not 100% going to tell you exactly what happened, right? If a kid has burns on the back of their hands, doesn't necessarily mean abuse, but these areas and the situation combined are a pretty good idea of what you could expect, right? So common types of burning that we'll see in abuse is going to be things like cigarette burns or small burns like that, curling irons, kids who have like burns on their thighs from sitting, as it looked like they're sitting in hot water. It's only burning that part of their area. And if you look at the bottoms of their feet or even at their buttocks, it's going to be a stark white from the skin getting saved by being pushed down. Potentially if somebody held them into hot water, that kind of stuff. Same thing if a kid's hand is fully submerged and burn, could be that somebody held their hand under a hot substance, because think about it, if you touched hot water, you're going to put it in and pull it out. But if somebody held it under, that's when you get the back of the hands, right? So just considering that as well. What makes sense in the context of the call? Does this seem like it could be abuse, or does it seem like a complete accident? Right? It's just one of those things that we have to consider. And we're going to talk about reporting and mandatory stuff a little bit later. So our proper care for burns, we're really going to get them. Yeah.
Quick question.
Sure.
So that little burn abuse chart, would that be very similar for, say, physical abuse as well, like hitting and stuff like that?
Sort of. It's different because with physical abuse, you can hit anybody anywhere. And with accidents, right, you can get hit anywhere. There are some ways, like, you know, depending on what type of abuse they're getting, specific injuries can lead into that. So like if we're talking about physical versus sexual abuse, different areas might have different injuries, that kind of deal. But there isn't like a cut and dry way. Somebody can tumble down the stairs and have injuries that look like they're being abused, and somebody can get abused and say they tumbled down the stairs. It can be very hard to differentiate. Yeah, good question though. So treatments for burns, scene safety and BSI, very important for us here. Unless you are on a fire service and getting your EMT, right, we're not going to be going into burning buildings. We're going to let the firefighters do that. They train, they have the gear. They are the ones who know what to do in that situation. For us, when we're treating somebody with burns, we definitely want to make sure we're being as sterile as possible. So getting them into the ambulance is a good idea sooner rather than treating them on the side of the road in dirt, that kind of stuff. We also want to make sure that we have moved them away from the area, right? If the burning building is 20 feet that way and they have severe burns, let's get them away from the fire. Let's just get them somewhere that they don't feel like they're going to die again. Same thing, we don't want it to hurt us. Fires can expand quickly and suddenly, even while under the care of firefighters. So we want to make sure that we get ourselves to a safe area with our patient. Burning buildings are quite hot. I went to just like one of those practice burns where they did a full structure fire, and I didn't realize how close you would be to the building for when your hair starts to like singe and you start to feel like you're going to catch on fire. It's very hot. So moving somebody away, very good idea. We also want to remove any like actively burning clothing that they've got. So if their shirt is still smoldering, right, take that shirt off, get it away from them. If they still have a burning chemical on them, we want to be extra careful. If it's like a powder and we have gloved hands, you can brush it away, but don't just go pouring water on it. We don't want to cause a reaction with a chemical that we don't know. So a gloved hand and brushing, that can be good. If it is just thermal, so like fire, we want to cleanse the wound with sterile water. We want to stop it from actually continuing to burn that might be on there. So you can neutralize it with sterile water, as long as it's not electrical, right? They're not actively being electrocuted. That would make it worse. You guys understand how water conducts. So thermal, put water on it to cleanse it after getting off the burning things. If it's a chemical, wipe it off with a gloved hand. We want to treat these burns with dry and sterile dressings. Now, this is a change relatively recent. If it was anything higher than a second-degree burn, we were saying treat it with a moist sterile dressing. But one thing that they've been researching at the hospital is that since temperature is one of the main killers of people with severe burns, not being able to regulate their thermals, if we coat them with water and keep it on them, we're actually going to be actively cooling them. And that's bad because they're going to be fighting. We're going to be essentially making their shock worse if we're making them colder while trying to actively warm them. So you can wet the wound to neutralize it, cover it with a dry dressing, and really try to keep these people warm. That is the biggest thing about burns. It kind of feels weird, right? Let's apply heat to this person who's had a heat injury, but you need to treat them for shock. So high flow oxygen, keep them nice and bundled and warm, and get them to the hospital as quick as you can. So specifically, these are what you might see. So these dressings, these burn sheets are sterile and they're just great for covering wounds. And then this is the water that you should be using. It's not just like a bottle of Dasani or Fuji water, whatever like that. It's sterile water, right? That's what we want to be putting on injuries. So again, prevent that body heat loss, treat the patient for shock. So supine, blankets, high flow oxygen. Get an estimate of how severe the burns are by looking at the extent, the depth, and just essentially where they are on the patient. You also want to do a good assessment so that you don't miss anything else. If somebody was injured prior to being burned, it's potential we could miss a severe injury. Right, somebody gets in a car accident, they get a flail chest, and then they suffer severe burns to their chest. It might be hard for us to notice that flail chest if we don't do a good assessment. So don't let the burns give you tunnel vision, right? We do want to treat those, but again, burns, there's nothing that we can do immediately for like a life-saving intervention. They're going to be in pain. Our biggest deal, treat them for shock and get them to the hospital. But if we miss a life threat that we're missing because we're looking at these severe burns, it could be worse for them. So we want to get them in the hospital as soon as we can. This is one of those situations where we don't have anything that we can do to help these people long-term. They need a surgeon, they need a hospital, they need a sterile environment. We can't provide that, but we can get them there. So chemical burns, again, these are going to be some of the more, to me, these would be super scary, right? I'm not a chemist. There are so many chemicals out there that we show up and it's a chemical burn. I'd be like, oh boy, I'm out of my depth, right? I'm going to call for some help. So you guys should have or will all do that hazmat awareness, right? So this is the whole purpose that we do that stuff. Chemical burns can be super severe and they can be really bad for the responders coming in if they're unaware of what's going on. So having a lot of help who knows what's going on with this situation, that's our best deal. There are plenty of times where hazmat will need to come in and do decontamination lines. Like anytime somebody goes in or out, need to be cleaned, all this kind of stuff. It can get really really cumbersome, lots of different people coming together to do something. So anytime you're concerned that there's a chemical burn or that's affecting a lot of different people or could, definitely tell dispatch, we're going to need some hazmat. Call fire. They've got people who can respond and do that initial kind of quarantine assessment of what to do. Otherwise, we have that flippy thing in our ambulance, just kind of that quick book of what the different placards mean on different trucks or different signs, what kind of chemicals to look out for. But in general, again, with a gloved hand, if it's stuck to their skin and it's a powder, brush it off, remove their clothing. And then depending on what's going on, we can flush it with sterile water, but we want to hold off until we know exactly what chemical it is so that we don't accidentally pour water on it and have it make a worse reaction. We also want to transport quickly to the hospital with good communication to the hospital prior to us getting there, informing them of what chemical, if we know, got on our patient so that they can set up an area that might be a little bit more appropriate for somebody who is coated in chemicals. There was, I forget exactly what it was. It was in Williston a couple of years ago. There was a plant that made like a bear mace. I think that's what was it? There was a chemical.
It was Casella Waste. Casella Waste has a facility in Williston. And somehow a canister of bear spray was set off. Ryan, if you were on this call, please correct me, but the bear spray was let out. Multiple people were exposed to it and it became a hazmat situation.
Yeah, not fun.
I wasn't there for that one, but we did actually have another one shortly after I joined, where there's some bear mace accidentally set off in a hotel.
Right.
Yeah, the Fairfield Inn, and it got into the air ducts, and yeah, little bit of stuff made a huge mess.
Oh boy, I didn't even know bear mace was that prevalent in Vermont, but we do have bears. So, oh, there it is. Look, I'm thinking ahead too fast. There's the book. Emergency response guidebook. So you can flip through and it will tell you what is going on, right? And I kind of answered my own question. We're going to consider fire, hazmat, anybody who knows about chemicals better than us. quick question for you guys. Just who is the most appropriate person to reach out to when we're dealing with like poisoning or chemical something like this?
Poison control.
Poison control.
Yeah, absolutely. I kind of, when I got into EMS, I was like, and they told me, yeah, call poison control. I was like, are you serious? I thought you were going to teach me everything I needed to know about this stuff, so I wouldn't have to. They're like, no, there are so many different things out there with so many different reactions. Call poison control. So absolutely do it. They love to talk to us. I had a patient who drank about half a gallon or half a thing of bleach. So I was just like, okay, get in the ambulance. And we got him in the ambulance. And I was just like, are you doing okay? He's like, yeah. I was like, okay, well, I'm going to make a phone call, called poison control. And they're like, oh, was it bleach? I was like, yeah. I was like, what brand? Told him the brand. And like, okay, yeah, just make sure he doesn't throw up, get him to the hospital. He'll be fine. I was like, okay, awesome. Right. That's very reassuring. That's all I needed to know. We got him to the hospital, took his vital signs, made sure he didn't throw up as best as we could. That's what they do. And if there's anything specific that you should do, they will tell you. Incredibly great resource. Call them if you have somebody who's ingested something that can be considered a poison. So with electrical burns, these ones are interesting. We also want to make sure, first and foremost, right, if somebody's actively being electrocuted, I hope you guys know this, just making sure, don't touch them, right? If they're actively being electrocuted, use something else to touch them. Okay, so like a broomstick or something that's not metal, because if you touch somebody who's actively being shocked, you will be shocked too. It's the same reason we say clear before we use an AED. Okay, if they're actively being shocked, don't touch them, get something else to do it. Once you've turned off the power as well, and the patient is no longer being shocked, that's when we can start assessing. Now, the interesting part about electricity is that it's not going to act like chemicals or like thermal heat. You're actually going to see an entrance wound and an exit wound. Because electricity courses through our body, it follows those paths, right? From whatever we're touching through us down to the ground, that's where you're going to see a path. So in this one, you can actually see they touched it in their hand, it went in through their thumb, and that it came out from their back. So there's actually an entrance and an exit wound. So wherever that electricity enters and then exits the body, it could arc. It can be pretty interesting. You can also see wounds like this, where it really looks like there's electricity coursed through them. This is one of those things you might see from people who were hit by lightning. Very rare that those people actually are okay, but they oftentimes have patterns like this. They also have severe entrance and exit wounds because a lot of electricity coming down straight through them to the ground. You might see something on their shoulder, find an exit wound on their foot. It's interesting how electricity does that. And then also when we transport this patient, if they've had a severe electrical burn, we want to make sure that we're ready for rapid cardiac arrest or sudden cardiac arrest. Who wants to gander a guess why?
Because it'll affect their heartbeat.
Yeah, because we have our own internal electricity going through us all the time. And if it's super disrupted, it could lead to sudden cardiac arrest. It's kind of the opposite of what we're hoping to do with an AED, shock the electricity back into normal. It's totally possible to shock the electricity out of normal, put them into cardiac arrest. So if they're doing okay, after being shocked, we still want to be very attentive, take an EKG, get them to the hospital, be aware that they could go into sudden cardiac arrest. If they could be put into an arrhythmia. Other cool fact for you guys about treatment of burns is that they've actually started to use fish skin in the hospitals as coverings for people with burns because they're extra protectant against like bacteria. Also, they're moist by nature and they have that exterior scaly skin. It's great for people with burns. So it actually keeps it nice and moist while also keeping it protected from the environment. Obviously, they don't just like skin a live fish and then throw the skin right on there. They do some treatment of it first, but it looks really cool, I think. I mean, I love sushi, so my issue, I'd probably be nibbling on it. But it's been doing a lot of work or a lot of good for people with burns, and I know that a lot of people or a lot of hospitals use it. Any questions about burns before we move on to more broader environmental stuff? And no, it's not appropriate to say, yo, sick burn to somebody who has really bad burns.
With the chemical burns, say if you're brushing the powder off, you should obviously probably have like a respiration device on. That way you don't inhale that at all.
Yeah, we don't. So the best respiratory devices we carry are N95s. We don't have like respirators. If we need that, hopefully hazmat would have told us before we start approaching those patients. But yeah, we should be wearing the appropriate PPE. So that's actually great. Thanks for reminding me about glasses, potentially even face shields, N95s if we're assuming that there's anything in the air, and obviously gloves. If it's anything, if we require any PPE beyond that, we should not be the people going in, right? We have a limited hazmat PPE. Hazmat and the firefighters will be the ones who are trained and have the appropriate equipment to do that. But yes, thank you. Always wear the appropriate equipment if something is aerosolized. Glasses, N95s, whatever you got, wear it. Anything else? Excellent. So, cold emergencies, temperatures. We have a lot of these in Vermont. It gets cold. I don't know if you guys have lived here before, especially around this time of year. I'm very shocked it's been so warm these past couple of days. Usually we're freezing. So with cold emergencies, we are going to talk about how the body can lose heat. So there are those different scientific terms up on the screen, right, about the different ways heat will transfer. So we've got conduction, right? So anytime that we're really like touching something, the heat will move from the hotter object to the cooler one. So that includes like somebody who is laying on the ground or the earth, if they're on the dirt or concrete, right? The dirt is an infinitely cooler object than you are. It is so big, it can hold so much heat that if somebody is laying on the earth, all of their heat is going to be sucked up by the earth. It's going to be going right into them, right into the earth, not them, right? So that's a big one, especially if they're laying out on the street in Vermont in wintertime. It can get really, really cold. So that might have us thinking, if I'm treating somebody for shock, but we're going to have to be on scene for a little bit, if they are just flat on the concrete and I've covered them with a blanket, I'm actually helping their heat be lost into the earth, right? So covering underneath where they are as well as over, that'll definitely help. We've got convection, so that's just standard. What we do normally, heat from our body leaves and goes into the cooler atmosphere. Evaporation, that's our body's own kind of way of cooling ourselves down. That's why we sweat. Besides excreting stuff, it's providing a platform for evaporation. It's the actual evaporation of that water that takes heat away. It's not the actual bit of water running across us that cools us down. It's when it evaporates. Radiation is just loss of heat directly into a colder environment. So being outside when it's cold. And then respiration, we actually lose heat through our breathing, right? If you breathe out from the depths of your lungs, right, you can make a hot breath. That's because you are getting rid of some of that heat that your body creates. So again, these things, I'm not expecting you to show up on a cold call and be like, oh, this guy is losing heat because of the temperature outside and the fact that the conduction and the convection is radiating from his evaporation. No, I don't really care about that. Just register if one of those things is present, your patient is going to be losing heat. And if you want that to happen, great. Sometimes we are actively trying to cool our patients down, but a lot of the times our main issue is trying to keep them warm. So we want to reduce the amount of times these things happen. So when we specifically talk about like cold emergencies, that's where we're going to be talking about hypothermia, so low temperature. And that's anytime the body gets below 95 degrees, so core temperature. Standard, we're at 98.6, relatively toasty. We'll fluctuate between 98.6 to 100, mostly 99. It's when we start to see temperatures above 100.4. That's when we really start to say somebody has a fever, when it doesn't seem within the kind of like standard deviation of the body's temperature, when it really seems something else is going on. So we consider hypothermia when somebody's below 95 degrees Fahrenheit. The weather does not have to be below freezing for it to be for hypothermia to happen. It can be really just kind of chilly outside, depending on the environment they're in, how much protectant they have, whether or not they are soaked in water or whatnot, can lead to different temperatures happening, or I mean, different temperatures leading to hypothermia. Again, elderly people and infants are at higher risk from this type of injury, specifically due to hypothermia. And there is also another very large population of people who are super susceptible to hypothermia, but I didn't put them on here. What do you guys think it is? What population?
Homeless.
Yeah, that is a really good one. people who don't have places to live, people who are pretty much forced to be in the environment all the time. That is one of them. What is the other ones? We have a lot of these in Burlington. Drunk college kids. People who are drunk are far more susceptible to hypothermia than other people. The reason being, alcohol is a vasodilator, makes you feel warmer because you have more blood rushing through your veins, all your vessels are opened up, but it actually reduces your ability to keep yourself warm. So people who are like, yeah, I'm just gonna drink myself a sweater. I don't need to wear anything besides my pumps and my skirt. No, you are losing heat. You are very at risk of hypothermia. There have been plenty of instances in Burlington where drunk college kids wander home, fall asleep in a snowbank, get snowed on, and are never found again because they die of hypothermia just from passing out or just thinking, oh, wow, I'm nice and warm in this snow pile, right? Doesn't work like that. So elderly people, definitely susceptible, even in their own homes, to hypothermia. There's a pretty common thing where elderly people will fall in the shower and are unable to get out or get help. And if they are naked and wet for a long period of time, depending on who lives with them, right, they can actually get very hypothermic, even in the summer, being in their bathroom if they've fallen and they can't get out. So you might respond to somebody in a really humid house, 85 degrees outside, and they fell yesterday in their shower. They were able to turn the water off, right? But they couldn't get out of the shower. They're shivering and their core temperature is below 95. You're treating them for hypothermia. It's definitely possible. So signs of mild hypothermia, pretty much everyone here, I'm assuming, has had if you've been outside in Vermont in the winter. You're going to shiver, right? Your pulse is going to go up. You're going to be breathing faster because your body's trying to warm itself up. It's doing all these things to keep you active. You're going to have kind of that first precursor to like frostbite. You're going to have the red kind of painful like fingers and skin when you get back into warmth, right? You're going to maybe even have some blue fingertips, really pale fingertips. Your cap refill is going to be reduced. And you're also going to have something called like the umbles. So mumbles, stumbles, and fumbles. You're going to lose a little bit of your ability to walk. Not like you're being drunk or anything like that, but you're just going to stumble a little bit. You might have a harder time picking things up. Like, has anyone tried to like type a text when their hands are really cold? You just can't do it, or just like can't grip something. It's along those lines. So you're actually demonstrating some signs and symptoms of mild hypothermia. Pretty normal, right? Like a lot of injuries and illnesses, our body can manage. It compensates. It has these natural things that we do to make it so that we can continue to do this for a little bit, but we will decline if we don't get to a better situation. So shivering, pretty good sign that the body's fine muscles, they're still working. It's that reaction that gets our body moving. It's kind of keeping us warm. It's getting us to be active. We're having our increased pulse and respirations so that we are, essentially providing more oxygen to our body to help it compensate. And then our body is going to close off or shunt the blood from our extremities into our core to keep our heart and our internal organs warm. But as it starts to decline, as we're not getting to a warmer place, our shivering is going to stop. Our temperature is going to continue to drop, but our body's ability to shiver is going to go away. So somebody who is close to death due to hypothermia or closer is not going to be shivering. So that should actually be a worry sign for you. If somebody's been really cold and they were shivering, and you're still outside and they stop, that's a bad thing. So it's going to just decline pretty rapidly. So they're going to lose their general muscular ability, right? That shivering is going to stop. And they're going to be more stumbly, more clumsy. And then it's just going to incredibly get worse and worse as their muscle activity is unable to continue. And this is when, people who are really hypothermic, they start to say, I got really warm, right? I felt really tired, really weak, but I felt really warm. And that's actually the body shutting down. It's no longer able to determine what's going on. That if somebody feels really warm and they're in the depths of hypothermia, that's a bad sign. It means that they are close to death, right? So they're going to start from being able to compensate shivering to slowing down like they're getting frozen, essentially. They're just going to eventually get into slow motion and eventually stop moving. And that's bad. When we get lower than 80 degrees Fahrenheit with the core, this is an interesting situation. When somebody is this cold, they could appear dead when really they are just severely bradycardic or in a coma. So one of the sayings that we have in EMS is no one is dead until they are warm and dead. So if somebody we find is, we're suspecting that they are in cardiac arrest due to hypothermia, we are going to continue our active work regardless of it if it's been a little bit longer of a period of time. We're also going to up our length of time that we're allowed to check for a carotid pulse to 60 seconds, because if somebody is super hypothermic, they could just be severely bradycardic. Their heart could still be beating, but like once every 30 seconds. So we want to check for about 60 seconds before we really commit. And if they're cold, we're going to start CPR. There is a caveat to that. If they are frozen in a block of ice, right, you can't compress somebody who is completely frozen solid. That is a difference. But we could potentially still transport that person to the hospital. If you're seeing other signs like factors of death, if somebody is cold, but you see clear like decapitation, you see clear lividity or things like that, that's a difference, right? There is a factor of death. They likely died and then got cold. So we are going to have to do some assessment there. But if you believe that this person went into cardiac arrest due to hypothermia, check their pulse for 30 seconds, and you are likely going to continue your CPR protocol. Patients who are actually put into cardiac arrest due to hypothermia tend to have a better survival rate than other people. Something to do with the body getting cold. It's like being in a refrigerator, and things last longer in the refrigerator. It kind of works like that sometimes. It's no longer in the protocol, but Vermont was participating in like a pilot program a couple of years ago with active like cooling of patients after cardiac arrest. So if somebody got ROSC, our protocol was to put this C-collar looking thing that was loaded with ice packs around their neck, pack their core with ice packs, and transport them to the hospital, because the idea was that it's actually preserving them and reducing their mortality rate. The study showed that it wasn't really helping, so we don't do it anymore. But the logic was sound, right? People who are frozen tend to have better results. So, hey, why don't we do a little artificial freezing ourselves? We also want to be very careful with these patients. If anyone's seen like those liquid nitrogen videos where they dunk like the apple and they drop it and it shatters into a million pieces. If somebody is really cold, our muscles and our bones and our ligaments are extra prone to breaking or snapping. So we want to move these patients very carefully, keep them supine, treat them for shock. And we don't want to massage any extremities. I know some people are like, oh, my hands are cold, like, let me just work some blood back into there. We don't want to do that, especially if they're really frozen or really cold, because we could actually be damaging their frozen skin, right? Ice is like little crystals. So if any crystals form deep in the tissues, microscopic ones, if we're massaging it, we could actually cause tears, rips, and blisters to form. And then we also don't want our patient to eat anything, and especially don't take any stimulants. Like if they have ADHD and they want to take their Ritalin, don't let them. I'm not entirely sure why. It's pretty much just, it doesn't react well with somebody who's been really cold. We could give warm humidified air if possible. We don't really warm up oxygen in our truck. There are places that you can like use a humidifier that warms up the air. Not a huge priority for us. If we really wanted to humidify air, we could put some water in a nebulizer, but that's kind of like a little bit janky. We're not going to spend the time to warm up that fluid. They really just need oxygen. And we want to do passive rewarming in this situation. Like if we put way too much heat on their really cold extremities or on where they are really cold, could actually lead to more severe injuries. We could cause, similar to how like if we would massage, we could cause blebs to form those blisters. So keep it nice and warm in the ambulance with good heat, give them blankets and stuff. And then once they've started to warm up a little bit, that's when you can give them a little bit more like hot pack, something to hold on to. But rapid heating actually has a lot of negative side effects versus passive rewarming. So putting them in a warm environment, that's the best thing to do. Also, especially if they're cold and dead, right? They don't have a pulse, or you're considering doing CPR and somebody who's been frozen, call medical control, get their input. This is always one of those times. Every patient is going to be a little bit different in this situation. It's always best to have a good cadre of people behind you to give you some ideas of what to do. So with cold, we do have a similar aspect to burns called frostbite. And so very similar to how we classify those burns, we're going to classify frostbite in the same way. It's about the level of the skin that it affects. So we've got level 1, 2, and 3. And the most commonly affected places by frostbite are going to be the face and the extremities, because those are the places that get cold and are exposed to the temperatures more often. For the first one, we've likely all had, it's called frost nip. It's when you've got those red, cold, and mildly painful fingers, right? So if you come back in from the outside and you're having, it hurts to move your fingers and you're warming it up and your fingers are tingly and it feels good, but it also hurts. That's actually a sign that you've got a mild form of frostbite. Congratulations, everybody. If you've experienced that, you have had frostbite. But doesn't leave any lasting injuries, just like the first degree burn, right? Not super severe. But with frostbite, we tend to see like the severity increase. When it gets to that second degree, it can get really bad. Specifically because we got those blebs. Blebs are gross and they just cause a lot of pain. It's coming from someone who's had them. Oh, worst pain of my life. So it's going to have a similar appearance to frost nip, but this is going to be characterized by those blebs forming. And that is typically on rewarming. So a lot of times people will escalate their mild to mild frost nip to frostbite because they go inside with their really cold hands and they immediately pour it under hot water. So what they're doing is, if it's been really cold to the point where those crystals can form in their skin, microscopic ones, they're putting water into their hands. It's causing injuries, causing fluid to accumulate, damaging tissues, damaging muscles, depending on the severity. So fast rewarming oftentimes makes these injuries worse. So it's going to be classified that second degree by those blebs forming. So it's going to be on that rewarming. They start to get swelling and it's going to be more painful, really bad. So these people, again, they're going to be at risk from similar issues to burns. So infections, depending on how deep like that actual freezing was, they could have some muscular or nerve damage as well. And then, classic frostbite, if it gets really bad, you get what looks like this. Essentially, they become chicken, like thaw or frozen chicken. It becomes hard. They'll make a sound if you knock on them. They completely discolor. They essentially freeze and the skin dies, the muscle dies. It gets really bad. This can also lead to just the extremities falling off. It can be that bad, where it's very similar to like liquid nitrogen. They can fall off. And it's going to be incredibly painful. Again, it's going to be painful, not on the fingers, but the places that are connecting to them. So I bet that section of the hand, right where it's underneath that severe frostbite, is the worst pain. I bet it's awful. So similar to treating anybody with like burns or frostbite here, we want to be super careful of moving them. Again, we don't want to accidentally knock off a finger. If we do, pick it up and bring it with you. But essentially wrap these up, very passively warm them, get them to the hospital. So remove the patient from the cold environment as soon as you can, get them into the warm ambulance, handle the injured part very gently, give them oxygen and get rid of any wet or restrictive clothing. We want blood flow to be prime, and we just want to make sure that they are not losing any extra heat than they've lost already. So even if it means you're going to be dripping in sweat in the sauna that you've got in the back of the ambulance, do it. The patient needs it. So bundle them in blankets. Lots of heat in the ambulance, high flow oxygen, treat them for shock. And then after you've kind of got them a little bit warm, you can start to do a little bit more rewarming, but we want to make sure we do it slowly. We want to keep them, we don't want to jump right into getting them super hot.
Are there basic parameters for that? Again, you're kind of saying like as you start to get them warm, is it core temperature that we're looking for to change, or is it extremity temperature that we're looking to change?
Core temperature, we want core up. We want to get it above 95, okay, just because that's that line of hypothermia. For our purposes, like the way that we can check temperatures are with either an oral or like one in the ear. I'm forgetting the technical term for it. But that's really it. And those aren't super accurate, right? If we wanted to be as accurate as possible, we'd use rectal thermometers. That is the most accurate core temperature you get, but we're not really going to do that to all our patients. So it's in the field, temperatures are going to be a rough outline. We want to get them back to a normal area, but it's not going to be one of those things we're going to be able to actively monitor. Like we're warming somebody up, we're not going to be able to say, okay, start doing this a little bit differently, like lower the heat because we're getting too high up. It's just don't give them hot packs. Don't like blast them with heat, get them into a warm environment. And then once they start to like self-report that they're warming up, their mental status is going to increase. Then you can kind of talk to them about, okay, are you still feeling really cold? All that kind of stuff. Then you can start moving it up a little bit. If they want to hold a hot pack or you want to start putting them in their pits or like against their neck, that's also acceptable. We just don't want to like directly heat with high temperature, like potential frostbite areas, because we could make it worse. That's really what I'm trying to get at. Did that help?
Yes, thank you very much.
Good. Any other questions, guys? Okay. So we did talk about burns. That's not what this heat emergencies is. This is going to be just environmental heat. So ranging from, like heat cramps to somebody full blown having a heat stroke. Heat emergencies are actually really severe, and seeing them, it's pretty intense. So again, normal body temperature, 98.6 degrees Fahrenheit. We can maintain that pretty normally. We naturally get a fever if something invades, and to a point that's okay, right? It's our body trying to kill it off. And we do have some backup systems, like we sweat if we get super hot, and that hopefully that evaporation would help us. But in places like Vermont, in the summertime, it gets really humid. And so if science tells us anything, humidity is just the percentage of air that can be maintained, water that can be maintained in the air. And when we sweat, our hope is that the air is going to take that water. It's going to evaporate. But if it's a super humid area, the chance of our sweat evaporating and going into the atmosphere is incredibly low because the atmosphere is already full of water. So us sweating doesn't actually do much. We just increase the amount that we're wet. Well, it does help a little bit. It can very much so hinder us, especially in places like Vermont. It gets very humid here. We have a lot of heat emergencies. Now, again, this will kind of ramp its way up. Usually, if somebody suffered from a heat stroke, they will have heat cramps and heat exhaustion on their way. So heat cramps is really just that first kind of warning sign that we are losing a lot of the electrolytes that we need from our body trying to compensate against this heat. So when we lose like the salt and all the other electrolytes that we need in our body, we lose that through sweat. And so the muscles have these reactions of cramping, and they can even get as bad as looking like this. Ouchie. Right? Like that does not look fun. And that can just happen from exercising. So like they're outside on a hot day, they ran a couple miles, they came back, oh man, I didn't eat a lot today. My cramps, oh, it's awful, right? Good news for them, they just need some liquids. Gatorade or electrolyte solution will really, really help. Rest, hydration, some food. That's really what's going to help these people. People with heat cramps, these are painful and uncomfortable, but replacing fluids, giving them some food and some rest, cooling them down, getting them into a cooler environment will definitely help pretty quickly. But it's when these kind of go untreated and the patient stays in that hot environment and they continue to exert themselves, that's when they can develop worsening symptoms. So heat exhaustion, also very common. Again, all temperature emergencies affect younger and older people a little bit more severely. But this can happen to a lot of different people. Young people who work outside or go outside all the time, or those who don't and then go outside. That can be a pretty big indication that or it could be a pretty big reason of why they're having heat stroke or heat exhaustion, excuse me. What you're going to see with these patients is that they're going to have very sweaty, cold and clammy skin. So they're going to feel pretty nauseous. They're going to feel really weak and ill. And they're going to be pale and sweaty. And when you touch their skin, it probably is going to feel pretty cool. That's the body. Again, it's losing its ability to compensate, ability to keep itself warm under this heat. And they're also probably going to be pretty thirsty and have parched mouth. So the best thing we can do for these patients is get them out of this situation, get them into a nice cool area. If you're just outside, maybe you're not even on duty, right? And you see these symptoms with somebody, they're outside, move them into the shade, get them some water, let them sit down and rest, tell them to stop exerting themselves. If you have Gatorade or electrolyte solution, give it to them. That's really great. This is just another precursor to heat stroke. So if they try to fight through this heat exhaustion, maybe they're saying, oh, I'm just out of shape, you know? No, you need to rest or else this could get a lot worse. Just lost my train of thought. So these people will have normal temperatures, maybe slightly elevated, but we're not going to see anything like over 101. It's going to be slightly elevated because the body's still able to compensate, but it's losing its ability to do that. So we want to remove anything that could be insulating them. So we do want to make sure that they're cooling down very quickly. That's the difference between cold and heat treatment, is when somebody is too cold, we want to heat them up gradually. But when somebody's really hot, we want to cool them down as fast as possible. So cranking the AC, giving them like a wet towel if they're just heat exhaustion or heat cramps, right? That's always good to pad their head, give them some extra evaporation. Oxygen is good. Remove them from that hot environment. So either into the ambulance with the AC cranked, into a place with AC, or out of the sun in general. You can have these patients lie down and elevate the legs. It's not to do with Trendelenburg, as far as I'm concerned. It just helps them with some of their blood flow, but it doesn't work for that shock, as we've been saying. So if they're alert, give them water, have them take small sips. We don't want to have them chug water because their body could react and have them throw up. So we just want to make sure they take small sips so they actually get that hydration. And if we do have electrolyte solution, like a Gatorade or a Powerade, if somebody has it on scene, absolutely, I'm going to have them sip that. And then also just be prepared to transport. These patients oftentimes are pretty easy to treat with some water, some cooling, but there is a potential they might need some fluid replacement if they're not able to keep that fluid down. So get ready to transport them to the hospital. Definitely a potential they need to go there. Now, again, if this isn't treated, that can lead to heat stroke, which is a severe and a life-threatening injury. So this is when the core temperature gets above 104. So it's worse than a very severe fever. It's like worse than the fevers people were getting from Ebola. And if we knew anything about Ebola, one of the things is that the temperature gets so high that your organs can actually start to liquefy just like a little bit. And you start to bleed out of all your orifices, and it's really bad. So when temperature gets really high, we essentially melt internally, and that's bad. We are cooking ourselves. And when our brain gets into a situation or an environment that's really detrimental to it, we start to act abnormally. So the difference here between heat stroke and heat exhaustion is that heat exhaustion, the precursor, they're still going to be sweating. They're going to be pale, cool, and diaphoretic. A sign that somebody has switched from heat exhaustion to heat stroke is if they have stopped sweating. Their skin is going to be hot, it's going to be dry, and it's going to be very flushed. It's a sign that they essentially are no longer able to sweat. That part of their body, that compensating part, is no longer working, and that's really bad. They will be very altered, severe altered mental status, sometimes even worse than like what you'd see from some like drug overdoses, like severe altered mental status. Chris and I, for multiple years, Chris, did you work this year at the marathon? No. In the past, Chris and I have been at the medical tent at the finish line of the Burlington Marathon. And when I was like learning that we could volunteer for this, I was like, oh, great, like treat some people with rolled ankles, a bunch of tired people afterwards. Oh, like just have some fun, do some medication stuff. No, it was like the most intense day of my, like, you volunteer at the ending of the marathon, you're going to see sick people. Like, whoa. It's insane. On one day, so like one of these marathon days, two people that I knew very well, very dear friends of mine who I hadn't seen in a long time, they both had heat strokes, like within 10 minutes of each other. This one person, we were born a day apart, and they lived in the basement of my parents' house at the time. I hadn't seen them in years. As far as I knew, they weren't in Vermont. I'm just like kind of in the tent, and we hear, oh, BFD's bringing a severe heat stroke. like get ready to dunk. So BFT comes burning in, we get the patient off, and I'm like, oh, hey, I know you here. You're having a heat stroke. Wow, your temperature's like 105 degrees. Let's get you in the tub, right? Got there out, was talking to their dad, put them down on the cot, was talking to them a little bit, and then I hear like a blood curdling scream, and I look up and my other friend is being carried in because she's flailing and fighting and kicking and screaming. Her temperature was also 105, like super high. It's really bad. You can have severe heat strokes. People who knew, like, they knew each other really well, clawing and screaming.
What was the
and fighting.
weather on that day?
So that day was probably like 85 and humid. This specific day was actually really interesting. They let the marathon start. About an hour later, they did one of those bulb tests and they canceled it. They said, if you're running, stop. And so many people just said, no, I'm running. I'm just going to keep going. That by the time they got to the finish line, heat stroke, heat stroke, heat stroke. It was really bad, like constant flow of people coming in. The good news is at the marathon, it's actually really interesting. At the medical tent, it's actually more equipped for heat injuries on the marathon day than UVM is like on a standard day. So if somebody has a heat stroke outside of the realm of the marathon and they go to the hospital will send them down to the medical tent for appropriate heat stroke treatment. So what you do, you get a big tub of ice water and you submerge them in it and you stir it like a big sangria with ice cubes. And that's how it works. And it cools them down. You insert a rectal thermometer that has a long tube or a long stylet, essentially. You put them in and you measure their temperature until it gets down to about 102. Then you take them out and their heat stroke will continue to decline. But the faster you can completely submerge them in that ice water, the better, the higher chance that they will survive. Really hard to do because every patient that I've seen who's had a really severe heat stroke doesn't want to get dunked in ice cold water and they are really upset and not knowing what's going on. So keep that in mind. It can be kind of scary and severe. And death can happen really quickly if their temperature continues to climb. I forget exactly the metric, but it's something ridiculous. Like the body, like when you're having a heat stroke, your temperature will increase by 1 degree, like every couple minutes, something like that. If it's really bad, I forget exactly the metric, don't quote me, but it happens really quickly. So if you get to that point of like above 104, you're just going to continue to tick up unless something else happens. And it can even get to the point where you're essentially, your brain is just cooking inside your own body and you're going to die. It's bad. So for our treatment purposes, getting them to the hospital, cooling them as fast as possible, right? We don't have a big tub that we carry around in our ambulances. That would be cool, but we don't. So getting them to the hospital is going to be imperative. So cooling them as fast as we can, getting ice packs in their armpits, in their groin, against their neck. That's going to be really great. Cranking the AC, getting them kind of moist, right? So that they can do some of that evaporating. That's going to be good. And if possible, right, if we can immersion cool them, that's good, but we're not going to delay transport to the hospital to think about a way where we could immersion cool them on scene. Cool them as best you can in the ambulance, get them to the hospital where they do have an immersion cooler. So you can cover the patient with wet towels or sheets. You can fan the patient aggressively, and you definitely want to notify the hospital of a heat stroke so that they can get the tub ready. It's not all the time sitting, waiting in use. They need to get that ice and the water ready. Just another note for you guys, if you are going to be the one who's submerging people, it is so common, so very common that when somebody gets an ice bath after they're having a heat stroke, they will relieve themselves unintentionally, urinate, defecate, so wear gloves. Also know that if you have a heat stroke and you're not the first person, you're going to be in a gross tub full of their pee and poop, but you're going to be doing better. Just so you know. Okay, so we will take a break here. It's 6:55.
That's a very nice train station. It's a very nice train station.
Oh, good. I don't know if I've ever been. All right, any questions come up while you were happily not listening to me during break? Anything pique your interest? Moving on then. So one of the special populations we're going to be talking about is specifically kind of geriatric populations. Now we talk about the geriatric population is quite a bit. Any type of injury or illness that we already kind of mentioned, right? It's potential for somebody who's aged to experience. We will see quite a few people who are elderly on the ambulance. They are pretty much our number one callers for a multitude of reasons, whether it's because they're more prone to severe trauma when in more severe instances, right? Like a trip and fall for somebody who's 18 might not put them in the hospital for a long time or change their quality of life. But somebody who is 80, 75, if they take a tumble, it could change a lot. So we're going to talk about just geriatric use of EMS, some of the unique characteristics of why they call the ambulance. We're going to talk about trauma, specifically with the elderly people. And we're also going to talk about elder abuse and just kind of abuse in general when we get into it. So elderly patients are approximately 22 to 33% of our calls nationally. So we go to elderly people quite frequently, not just in like nursing homes and stuff, although those are also frequent, just around in our environments. We live in Vermont. Vermont is a pretty elderly community, especially depending on where you are. If you're out kind of more in the rural areas, there are quite a few elderly people. And then also in places like Shelburne and Charlotte, they just have very large elderly populations. The use of EMS, it just increases in frequency the older people get. So people who are between 65 and 85 use EMS 3 times more than anybody outside of that window of age, right? They are constantly calling the ambulance for a multitude of different reasons, whether it's a health issue that they've been dealing with, whether or not they have a ride to the hospital for something that might be just something they could deal with their PCP, a whole bunch of different reasons. So you're likely going to be transporting quite a few elderly people in your time on the ambulance. In general, as we get older, everything kind of just stops working as well, right? Unfortunately, that's kind of part of being human. We get older, our systems that we have stop working as well. It's just like if you ran a computer for 85 years straight, right? Shutting it down, you didn't even shut it down, you just let it sleep for about 7-8 hours every day. It's gonna shut down after a good long use. And it's just because those components, those parts, they wear down, they're not able to do what they're supposed to do. So some of the more common things we'll see, and just in general with people who are aging, is things like stenosis, so narrowing of our blood passageways, making circulation worse, increasing risk for stroke and heart attacks, that kind of stuff. You're going to see cardiac hypertrophy, so the thickening of that heart wall, so the heart is getting nice and big, it's not able to collapse on its own, or it's not able to collapse as well. Dysrhythmias, so the electrical activity in the heart not acting right, things going wrong. Arterial sclerosis, so hardening of the arteries, building up of plaque, just from general wear and tear. Specifically with their respiratory system, we're going to see just a decrease in size and strength of the muscles that kind of operate respiration. So not only our diaphragm, but also just our chest wall muscles and our intercostal muscles, right? They are used to help, but their ability to be backups is gonna decrease. Specifically, like with the decrease of those smooth muscle fibers, that's what we're talking about, those internal intercostal spaces. And then also they're gonna have that diminished resistance to infection. So a really big cause of elderly death is pneumonia and respiratory infections, because those can start off pretty like standard. Somebody who's a bit younger might be able to fight it off, but it can get worse and people hang around in the elderly populations and even lead to some severe sepsis. A lot of people die from pneumonia sepsis. With their brain, we see just a standard decrease in mass and weight just from age. They have potentially an altered ability to perceive hunger and thirst, right? They just lose that kind of the immediacy of that sensation for you and me. Me, I'm constantly drinking seltzer and water. You guys see that? I just constantly intake fluids. But there are plenty of people who are elderly who might be like, no, I haven't had a drink in a couple of days. I'm just not thirsty, right? They just might not recognize it. Or no, I don't need to eat. I'm okay. If I do eat, I get a stomach cramp or whatever. And they just end up not eating or drinking for a long period of time. They're going to have diminished sensory perception. So just in general, walking and feeling, right, can make it a lot harder. If you don't have good feeling in your legs, walking is going to be a lot harder, especially combined with maybe a diminished ability to see, right? Having cataracts or glaucoma or something along those lines, making it difficult. So everything combined really just kind of adds up. And then musculoskeletal system, quite a few things happen here. So we can have osteoporosis, which is just this kind of a, it's essentially the hollowing of the bones that become less strong, and they develop like those pores. Kyphosis, which is just kind of that hunched over bit of the spine, right? That shape actually develops naturally, and it's not that an elderly person like that standard kind of what you'd see in movies is that they have put themselves there. It's just that over their age of posture and their muscles and their spine, it eventually will end up curling like that. They have something called kyphosis. So especially with patients with kyphosis, treating spinal injuries can be a lot more difficult, right? Their spine is just naturally not straight. So laying them flat on a backboard, why were we doing that so frequently, right? Putting somebody who's normally straight up like this, forcing them to try to do that, it's not comfortable and it can lead to more injuries. So having a recognition of what their natural body shape is and padding those areas, making sure they feel comfortable. If you need to immobilize them, that's going to be important. And then we're also going to just see in general more pain throughout daily life. So arthritis, potentially just old injuries, or just losing their muscle tone. So moving could lead to being super sore or just being in pain quite a bit. The skin gets a lot thinner, right? I mean, there are plenty of times where you can say, wow, yeah, that is like old person skin. It just definitely looks thinner. They get those wrinkles. It sometimes looks like it's just hanging off the bone, right? This is caused by like a deterioration of that subcutaneous layer, that fat tissue. It's not all nice and plump. It's getting kind of loose. There's less attachments between the tissue and the dermis and the epidermis. And these patients are really prone to like sores and tearing injuries, even from just sometimes minor things like pulling somebody or something, or rubbing their arm against, getting caught on the door frame. It could tear that skin right off. I showed you guys that picture of the woman with the severe avulsion because she fell on her cane on just the wrong angle, and her combined with her skin and that little bit of sharp really tore right down into her skin. And they might not notice these as frequently because they have that reduced sensation, and they might not notice that they have that wound or the amount of them, and they can let those get infected because they just generally can't feel them as much. Specifically with the skin, we want to be cautious. If you're working with advanced providers like paramedics and you're setting up IV things, really strong adhesive tapes can be really painful to remove off of elderly people, especially if they've got really thin skin. You can actually cause injuries by doing that. So be very cautious. The other things that you're going to see with elderly people in their skin is that they're going to be harder to do interventions on. So like doing IVs are tricky. So having an advanced provider there definitely going to be helpful. But in general, when it comes to the skin, we just want to be extra cautious. And also just note that a lot of times bruising and bleeding in elderly patients can look really bad and severe. We definitely want to treat it like that. Like traumatic injuries with elderly people, definitely high priority, high suspicion of injury. But we also just want to recognize they can get and look really bad from just a small bump or bruise. Other joys of getting older, right? Elderly can suffer from multiple illnesses or diseases. A lot of times they compound on each other, really just affecting this person's quality of life, which leads to polypharma. So this is an actual image that somebody took of a patient's medication and history chart, and it actually spans the distance between the earth and the sun. It's a fascinating thing. This person's really sick. But sometimes you're going to go to a nursing home and you're going to be like, do you have any information on the patient? And they're going to hand you this like 1,000-page War and Peace where you flip through and you see all of the different medications they've been prescribed over the past 10 years. And it's just ridiculous how many medications they're taking for how many different side effects, how many different diseases. Like it's incredible that people will take this many medications. So we want to keep that in mind. With all of these meds, there are so many different interactions, and we are never going to be, as EMTs, paid enough and understand all of these medications enough to go into that amount of depth, right? I'm not expecting you to learn what all medications do. If I was expecting you, this would be a pharmacy class. So just recognizing that there's going to be a lot that we have no idea what could be happening due to how many drugs are in some patient systems. So really treating them for what we know how to do, airway, breathing, circulation, all that kind of stuff is going to be important. Don't get bogged down by the amount of medications that they have. Just get familiar with some of the big ones for things that we're concerned about. And then for the most part, that's really what's going to help you. So social aspects are really important when it comes to the elderly populations. When an elderly person lives healthier, or a person lives healthier, right, it can mean, or it leads to just a longer social kind of ability in your age. You'll be more, if you live healthier throughout your life, you'll likely be more healthy in your elderly years, which means you'll spend more time around other healthy individuals. Socialization is also really important. One of the big things that we see in elderly populations is just isolation socially. Now, if you get too ill or weak to actively leave the house on your own and your friends are the same way, or they've all died off, right, you're going to be kind of sequestered to your own world. You're not going to get much interaction with other people. So this could lead to some issues. People who are tending to be alone all the time tend to be less healthy. But there are some other considerations that we want to have to keep in mind. So what are some other potential medical considerations for an elderly person who has an active social life?
STDs.
Yeah, you got it right there. I love it. STDs. I worked in a nursing home. It was my first job in high school. I was in the dining area for a assisted living facility. So I was a host. So I just stood up there and took orders and stuff. I tell you, I've never been to a place that is more like a high school cafeteria than this nursing home cafeteria. Like, there was so much drama about who sat with who was dating, all this kind of stuff. It was ridiculous. And that's one of the things that it can lead to is a lot of people, elderly people who are in these nursing homes, yeah, they want to have sex. And what they don't necessarily have is the education or the ability to prevent STDs, right? Kind of thinking, hey, we're too old to be able to have kids, so we can just do whatever we want. But herpes, chlamydia, gonorrhea, all that kind of stuff, syphilis can be rampant in nursing homes because they don't have the protection. They don't really think about it. It can definitely happen. So if you are responding to altered mental status in a nursing home and you've gone through all your different things, finger stick is good, stroke exam is negative, they haven't had any drugs or all that kind of stuff, an infection, long-term, like underlying infection, could be one of those causes. So just keep that in mind. So a big part of majority of times that we're going to be treating the geriatric population, it's not going to be life or death. A lot of times we are just going to have to be present for them and be patient and help them move and all that kind of stuff, bring with them what they need. So I just put together some do's and don'ts, especially for people in our roles here. So we definitely want to be patient. A lot of times elderly people will be extra slow and it can be kind of frustrating if they're really taking their time, but that's just part of the job. Be patient with our patients. Allow for autonomy. So allow them to speak for themselves. One of the things that we tend to see is, like, if somebody's been really sick for a long time, their caretaker or their family member will like to tell you how they feel. Definitely don't disregard family members' input, right? They know that person better. But if that person is telling you something that might sound a little bit different than what the family member is saying, listen to your patient and take into account what the family member has to say. Speak clearly as best you can. Don't speak slowly and like this. Can you hear me? That is degrading. But speaking with enunciation and using your lips so that people can potentially read them definitely helps. Okay. And then you also want to probe for significant complaints. So a lot of times elderly people, they don't like to complain. It's just one of those things that we've seen. Oh, I have this pain or this thing constantly, so don't you worry about it. It's really okay. It's only a little bad, right? Investigate everything. Sometimes those minor things that they're complaining about can lead to be something big, right? Oh, I have just a small cut on my arm. It's not that bad. It's just a little bit red and sore. You look at it and it's a small cut, but it's green and pussy and they're having signs of sepsis, right? Dig into it a little bit more. Definitely don't use pet names. So sweetie, honey, pops, Gma, don't do it. Say, sir, ma'am, ask them what their name is and call them that. That usually works best with everybody. And again, don't disregard the patient for family member reports, and don't ignore seemingly small things. Do your best. A lot of times these patients might not be verbal. They can't communicate to you, and you might not have a family member, just a nurse who from a nursing home who always says, you know, it's not my patient, I just showed up, right? Always investigate your patient, treat them honestly, treat them sincerely. And this will make you, well, this will take you from like a good provider to a great provider, is thinking ahead of what your patient's going to need, especially in these elderly populations. What are they going to need at the hospital to make their life okay, right? They need glasses, if they need hearing aids, if they need dentures to eat, bring them with you. If they're not a severe patient, ask them where they keep it, go grab it, bring them. Do they need a cell phone? Sometimes the patients forget that, right? Do they need a cell phone charger? Do they need their little book of phone numbers? What do you need when you're going to be at the hospital? You might be there for a couple days, right? What do you need? I'll bring it for you. This can even include like home oxygen. So not necessarily bringing tanks, right? But if somebody's on home oxygen constantly and they have a nasal cannula, leave one behind if you're going to take them with their home oxygen to the hospital, or leave their nasal cannula at home, take them off of it, put them on yours, get them to the hospital, and then leave theirs at home. Consider that kind of stuff. Like after they get home from the hospital, are they going to realize, oh crap, that EMT took my last nasal cannula, and now I don't have anything for my oxygen. What am I going to do, right? Leave one at home for them. That's just those kind of forethoughts. Most common kind of trauma we're going to see with these elderly patients is falls. Happens all the time, very frequently. When people get older, right, they lose their balance, they lose their ability to register kind of where their feet are. So falls from standing height, very common, and also pretty severe. A lot of elderly people will be totally self-sufficient, healthy and strong. They take a one little fall and it can really, really ruin, it can really tank their quality of life, because their ability to heal and then be able to physically move and participate in like physical therapy, just it's a lot harder. Very commonly, do they break femurs, break hips, arms, shoulders, ribs, necks from these falls? It can be really bad. And it can look really bad too. There was this woman who fell, probably in her 70s, early 70s. And she said from her report and from people who watched, she slipped and fell and then kind of like just skidded a little bit on her face. But when I got there, it was literally like Two-Face, so black and swollen and just like big, right? It looked like she had been just demolished. But everyone there, including, yeah, I just slipped and fell. I have no idea why it looks this bad, right? It's just kind of how their bodies react. Other common ones are going to be motor vehicle crashes. Again, this kind of goes into just hand-eye coordination just in general, right? And again, any sign of like significant trauma can be really, really deadly for elderly people. So if they're in a car accident, definitely high mechanism of injury, we want to do a lot of assessment. So that's going to be like that spinal motion restriction, all that kind of stuff. For treating falls, we have that special stretcher called a scoop stretcher, which allows the patient to be picked up without us moving or rolling them to get the board underneath, and they can be picked up in a position of comfort. So if they're laying on their side because they broke their hip, we can connect it around them and pick them up that way. That's going to be really great for elderly people in falls. But we also know that if they have pain after trauma, we have to control their C-spine. So we're going to put a C-collar on them, all that kind of stuff. Burns, also pretty common with elderly people. Again, reasoning is because they have less of that tactile sensation. So when we might, touch our hands really quickly to something hot and move away, it might take them a couple extra seconds to register. And a couple extra seconds when it comes to burns can make the difference between mild first degree, just kind of irritating, to really bad third. So we will see burns in this population as well. And just in general, we're also going to see everything else that we've covered. So we're going to see cardiac issues. We're going to see respiratory issues. If somebody is in their older days, we're likely going to see more severe, kind of more exacerbated types of these illnesses. So they have been living with COPD or CHF for a long time. They could be diabetic for a really long time and have neuropathy and necrosis, all that kind of stuff. So just in general, similar to how we take a little bit more or a little bit more suspicious of injury and illness when it comes to kids, we're going to be very similarly suspicious when it comes to elderly populations. They are just far more at risk and far more likely to get severely injured or sick from something that might seem relatively not severe to somebody who's younger. Elderly people are also at an increased risk of abuse. Similar to kind of how when we were talking about, their friends die off, they become more dependent on family, whether it's a spouse or kids or other family members. And that can be a huge burden on people, especially when we're talking about money and time. If all of your attention needs to be focused on like the elderly person in the family, it can actually wear down on a family quite heavily and lead to whether it's intentional or unintentional abuse. Neglect for elderly populations is a high issue. So this is up to you. Not up to you to fix, but it's up to you to report and to assess for. So as EMTs, since you guys should know this, and you will be taking, if you haven't already, that mandatory reporting kind of course online, we are legally required to report if we are suspicious of abuse. So that doesn't say that we are legally required to report confirmed abuse. We are legally required to tell the state anytime we're concerned that there might be abuse. Anytime we get that kind of twinge in our stomach that says, I don't know. Okay. So some highlights from this is we don't do that very well. Not saying that you guys won't. I'm saying in general, as EMTs and people who are mandatory reporters, we don't do it very well. And there's some good reasons for it, but it's not acceptable. Some highlights are that around 70% of people who were suspected to be abused were, and around 2/3 of people who were legally required to report it did not. So that's on us. And that's really what we're going to be talking about right now is this mandatory reporting kind of deal. In our previous class, we actually had somebody who is like a manager at DCF in Vermont who gave us a really great talking to about what goes on behind the scenes. But in general, DCF is our friend, and we're never going to get in trouble for calling when we're just suspicious, right? That is what our job is. You are legally required to do that. Okay. Anytime you are suspicious, anytime, call, make a report, move on. Okay. So challenges for us is determining whether it is abuse or not abuse, right? Unless we show up and we see somebody actively physically abusing somebody, we don't necessarily know. Even if someone tells us, yes, they abuse me, we're not judge, jury, and executioner. We can't say they abused you. We can listen to that person. We will report that because they self-disclosed it, but we are not the ones who are saying you were abused. Okay, we can't be that person. So what we're going to be looking for is anything that makes us suspicious, right? So physical abuse. So anything that looks like it's been repeatedly hit, right? Somebody who's got like black eyes all the time, cigarette burns, broken arms, bruised ribs frequently, right? We're going to look for signs of sexual abuse. Matt, you're asking if we should urge them to report the abuse. So we want to encourage them to get out of an unsafe situation. So if they tell us, yes, my husband abuses me or my wife abuses me, we want to say, do you have anywhere else that you can go? But we're always going to advocate for them. We're going to report after they're out of our care. So after we get them to the hospital and move on, that's when we'll call the state and say, hey, this, and this happened. This person told me this. This is my name and my badge number, essentially. I'm submitting a report. If you need me, call me back. They'll do all the investigation on their side. And from there, they might put them in a different situation. We can always advocate for them. But
What
they're
about in
not
a situation where you don't transport?
Yeah, we want to urge them to get out of a situation. But again, we aren't the people who are going to fix this abuse. It's tough. It's like all we can do, same thing for like if somebody is dying and we want them to go to the hospital, but they say, hey, I want to die at my house. We have to let them do it. So if they're like, yeah, I'm being abused, but I kind of like it here. All we can say is, hey, that doesn't sound great. You should definitely reach out to the police. But
if there was like an instance of rape, wouldn't we be urging the patient to maintain the evidence until they arrive at the hospital?
Absolutely. So if we are going to transport somebody who's been raped, essentially, we want to maintain those policies. So we're going to advocate for them to follow these things. We want to put any clothes in a paper bag instead of a plastic, that kind of stuff. So we want to be able to help for the assessment of the case. But if they don't want to be transported, we can't make them, and we can't make them report what's going on. All we can do is report on our own. Chris, you're raising your hand.
I would say that's going to depend on the patient themselves, right? And so are they able to make those decisions for themselves? That's the other thing that you should think about. If they aren't. It's, sexual abuse of the elderly actually happens more than we would like to think, but a lot of the cases aren't investigated because a lot of them are happening in care facilities. And when patients are reporting it, they're saying to other caregivers, hey, this is happening to me. A lot of times they're not believed because maybe they have dementia or Alzheimer's. And so they're not believed. And a lot of times they're not investigated. Decisions about whether they go, are they able to make decisions for themselves? Certainly, at the very least, we need to make sure we're reporting. Don't be the provider that went to the nursing home and had the patient tell you, I'm being I'm being sexually assaulted at night. Some guy comes into my room every night. Don't be the person that doesn't report that, because that's bad. So,
yeah. Steve, what's your question?
So I was just having a question about say that there are hints and stuff towards abuse of our patient, but the aggressor abuser is still in the area, and we're trying to treat our patient, and then the abuser gets very aggressive with our staff members, people that we're working with, or yourself in general. Is that also concerning scene safety, where we have to make sure that we stay safe, and if we have to get out of there, then we just get out, right?
Yep. If at any point anybody on the scene starts to turn violent towards you, if you can take your patient with you and leave, absolutely do that as soon as you can. If you can't take your patient with you, but you're still in danger, leave. It's going to be challenging. It's going to be tough to leave somebody who might be in a bad situation, but if you're in danger, you got to get out of there, because you can't help somebody. You need to call the people who can. So if the police are on scene, they should intervene. But if they're not, you get out of harm's way until police can get there and make the scene safe, and then you can go treat your patient. If that means you're going to be coming back to treat a more severe patient, unfortunately, that's how it's going to have to be, because you can't treat somebody if you were dead yourself. Yeah, so this topic is a tough one, because a lot of times we're going to have to use our gut. And again, we can't all the time tell the patient what to do. But we can always just advocate for them and do with what is within our legal rights. And we are legally required to report this. Okay. Even if somebody doesn't say to you, I've been abused, but you have the slightest suspicion, do it. You are not going to be the nail in the coffin that ruins somebody's life with a report. Okay. If you report it, DCF investigates it, and they find out no abuse, great. They have just confirmed that there is not abuse. If they investigate it and your report has just added on this pile of evidence to all these other sorts of cases, and then they find it and it was abuse and it's stopped, you have helped stop it. Okay. There is no lose in this situation. It is only beneficial. Okay. But it is challenging to do. Specifically, when I was working at the high school, there was this student who was physically, mentally disabled. He was in a wheelchair. He had severe MS, wasn't able to communicate all that often, right? He used a touch board that was really hit or miss. he could say things like yes or no. For the most part, he would come into my office and he'd ask for crackers. I'd give him some crackers, water. We'd hang out pretty much every day. So one day he came in with his caretaker, and the caretaker was saying he normally had absence seizures, but he was having a little bit more than normal. And he had just gotten this fancy new like electric wheelchair that moved really fast. Like he was booking it down the halls. So his caretaker said he had a seizure, and it seemed like he slammed his chair into the wall a little bit. So we're like, okay. And we know that startling him makes him have seizures. So we brought him into the office, just doing an assessment, and he was having seizures. But when I went to go just do like have him squeeze my hands, he like was pulling his hand away. And I was like, oh, okay. So I did a little assessment, and it looked like one of his fingers was kind of red and swollen. So I was like, oh, you know what? He may have banged his hand into the wall with his chair, hurt that finger, which caused him to have a seizure because when he gets stimulated. So I called home, said it was pretty swollen. There's a potential it could be broken. We don't know. Please get it checked out. This was on a Thursday. So the next day he comes in first thing in the morning, goes to my office, and he just says, ow. And he never really communicates or anything. And so he said, ow to me. That was the only thing he said. I was holding up his hand. So I went over, looked at that finger. It was massive, swollen, bruised, and obviously broken. So I immediately called home, said, hey, your son's finger is broken. It was maybe yesterday, but now it definitely is. Bring him to the hospital. And when I talked to his mom, she said, no, his finger's not broken. I know my son better than you do. I know how he speaks, because it's not broken. Because when I grabbed his finger and I moved it around, it didn't move in any weird angles. It was fine. He didn't say ow or anything like that. His finger's not broken. And I said, are you fully aware of how inappropriate that is? Like, you don't do that with somebody who has a potential broken injury. And she was like, whatever, blah, blah, blah. Like, I know my son. You don't know my son. I absolutely refused. I said, he's not going to leave my office until he goes to the hospital. If you don't come get him, I'm going to call an ambulance because he needs to be seen for this finger. Dad comes and gets him. His finger was broken. So as soon as that happened, I didn't want to do this because I had been speaking with this mom all year. I'd gotten a good relationship with her and the son. I called and I had to report, because to me, it wasn't that she was physically trying to hurt him, but that was neglectful. That was not what you should be doing, especially to a student or to somebody who can't like speak and advocate for themselves. So went through the whole process, reported. DCF is really great. They follow up with you. They'll give you a call back. They'll send you a letter once the case is closed. Everything was fine. It was all closed out. They never learn who calls and does the report. I'm sure they may have guessed in this situation, but that's just the process. That's what you're supposed to do. So I didn't want to do it, but I was legally required to. So, hey, guess what? You got to do it or you're breaking the law. You're only going to help somebody. So if you ever have the slightest suspicion, make the report. And it doesn't have to be like your whole crew agrees. The crew chief says, I'm going to make a report. If everybody else on the crew is like, no, that's stupid, you don't have to do that, I don't think there was abuse, you're good. Like, it has to be a majority. No, it's whoever feels suspicious, you make a report, right? If your crew doesn't agree, screw them. You make your own report. Okay. I'm being hard on this because you saw the metric. 2/3 of us don't do this. And a lot of people are abused. And especially because we're the people who are seeing their home life. We know. Okay. We are the ones who are in their house, not the doctors, right? We are in there. We know what we see. Now this can even be even more challenging because we went into Winooski, and there's a lot of different cultures that live in Winooski. We got a report of somebody who had been beaten, essentially. We show up. It is a non-American family. I don't remember exactly what culture, but there was a father, a brother, and the victim who was essentially just beaten to a pulp, like really messed up, not in severe threat of death, but very badly beaten. The police were speaking to the dad and the brother. We were treating the patient. We were making sure it wasn't rape and all that kind of stuff. The patient was amenable, wanted to go to the hospital just to get checked out. So not asking these questions in care or in earshot of the brother and the father. But when we get into the back, I ask, hey, do you feel safe at home? Do you know who did this to you? Like that kind of stuff. And she had finally admitted to us, yeah, it was my dad and my brother. And I was like, oh, those two guys. And like, yeah. And I was like, do the police know? And she's like, yeah, I told them. Yeah, it's totally fine. I'm like, what are you talking about? Like, you're really injured. She said, well, they found out about my American boyfriend. So they beat me up. That's kind of how it works. And I was like, are you serious? She's like, yeah. Like, I shouldn't have been dating that guy. And so we called and filed a report, but she probably wouldn't have wanted us to, because that was how it kind of goes in their culture, right? Cultural relativism, something along those lines. Every time I spoke about culture, there was in a previous class, this one kid would just type that in. It's true, right? We live in our own society. We have our own culture, as intricate as it is, but there are other, especially in Vermont, Winooski is a refugee center. There are a lot of very new cultures to ours. And there are going to be plenty of times we have to be amenable to that. So there are cultures like the Somali culture where a man is not allowed to touch a woman unless he's married to her. So if you have an all male crew, oh boy, you're going to need somebody else to come and help. Because you show up, say, hey, absolutely, I'm here to help. Can I check your blood? Can I check your pulse? And you're going to get swarmed, right? We have to be amenable to that. We're never going to go into somebody's house and just tell them that they're doing it wrong. We're going to go to help. So that is all going to be considerations, right? Whether or not they think it's abuse, we still have to report it if we know that it is. So this can lead back to geriatric populations too, with neglect, right? Oh, my grandson, Johnny, he's kind of hit or miss. He's supposed to bring my food. He hasn't come in like, 3 weeks, but it's okay. I've been doing okay. I can manage. No, right? That's neglect. Not getting food in 2 to 3 weeks. That's neglect. Abandonment, right? Just not showing up, not doing anything, just leaving them there, or bringing them to a nursing home to say, here, take them. Right? Unfortunately, having worked in a nursing home in the kitchens, and then also working in nursing homes on an EMS side, they're not great. There are a lot that are really fantastic. I'm not saying that every nursing home is bad. I'm not saying that everybody who works there is an awful person. Absolutely not. I worked there. Okay. It's just that a lot of times these systems fail our patients. Like a lot of patients not taken seriously, not listened to, just kind of thrown into this whole essentially like prison aspect of, you get your meal at this time, you're in your room at this time is movie hour, and if you deviate, well, you're going to get a talking to. Okay, it happens. We would frequently go to Green Mountain Nursing Home in Winooski, and if you're in like District 3, personally, like there are sometimes like treatments there are lacking. My favorite story to tell about Green Mountain Nursing Home was relatively new still. We got a call for cardiac arrest, CPR in progress. So we could go flying down the road. We call a medic. We show up. We back in. We get out. My crew chief looks to the person who met us there and was just like, "Our compression's in progress. How many shocks have you given?" And the woman is like, "What?" We're like, "You called for CPR in progress. Do you have an AED on? Like, what's going on?" As we're walking through the halls. You're like, no, none of that. And we're like, what are you doing then? And we get into the hallway. I see a woman in the fetal position, like a grown woman, a nurse, rocking back and forth, sobbing. We get into the room. There is a very angry, conscious man, older gentleman sitting on the chair, kind of batting at some people, and like 3 other people kind of like screaming and running around, trying to find his paperwork, trying to talk to him. So we get everyone to calm down. We're like, what happened? They hand us the paperwork. And they say, we went to move him and he passed out. And the woman out in the hall was the one carrying him. He just slumped back in his bed when she was like, he's dead. I checked the pulse and he's dead. And she was freaking out. The crew chief kind of just hands me the paperwork because I was the third and I was going to take notes. On the front cover of this person's information, in big bold letters with stars and highlights, caution, orthostatic hypotension. Patient will pass out if stood up too quickly. On the front page. Okay. So these things happen quite frequently. Medication mix-ups. People take too much of their medications or they get skipped. They don't eat. Abusers love these places. It's really bad. It can get bad. There are plenty of good places. Just keep it in mind. Even if you are going to an organized business for these people, keep your eyes and ears peeled. There might be abuse. That's my rant. So domestic violence, 1 in 3 women and 1 in 4 men are abused by a family member or a spouse. One thing that frustrated me just a tad was if you search domestic violence to look for images, you can not really find any of a woman abusing a man. It's always a man abusing a woman. Domestic violence against men is highly underreported because of how men are told to be. Oh, if you're getting beaten up by your wife, well, you must be kind of an idiot then, right? Who would let that happen? So just keep it in mind. Just because your patient is a male does not mean he's not being abused. Okay. We are prone to biases just as everyone else is. If you're going to be on EMS, check your biases. But when it comes to domestic violence, what is our job? What do we do?
Make sure the scene is safe.
Yeah, absolutely. Right. We don't want to get into an actively violent situation. But when
And
it
just
comes down
report
to
it. We just report it.
we're going to report it, but we're going to do something else first. We're going to treat our injured patient. Okay, just because it's a domestic violence call does not mean we are not going to continue to treat our patients, right? So regardless of what they feel about the situation, we're going to treat them as best we can. We can make changes to our traditional care depending on the situation, depending on who the abuser is, what the situation is. If the patient would prefer like minimal talking, if they want to have the lights down in the back, if they would prefer a female or a male provider, whatever it is, try to be amenable to them. Register that they are in a bad situation or just had come from a bad situation. Document what you saw on scene, what happened during the call, what the patient said, report it. That's really what we do, right? Unless there is an actively unsafe scene for us, our treatment is not really going to change. Report, report, report.
If we go on a domestic violence call, and obviously the police are there, we don't have to make a report on ourselves that we saw the domestic violence because the law enforcement's already there, correct?
You do. You have to do it. So even if police is there, you are not reporting this to the police, you're reporting it to DCF.
Okay.
Okay. So the police will make their own report. It will be like their own crime scene investigation, but we still want to report to DCF of what we saw and that kind of stuff.
Okay. Thank you.
So Nate had a question. Oh, I see this now. That's you. We actually just called a number for Vermont DCF. So there's a website that I had linked back there. You just call that number, tell them why you're calling, and they'll direct you out. There's somebody there 24/7. So other things that we want to be keeping an eye out for, along with the abuse can tend to be one of those signs that shows us that something far worse is going on, specifically human trafficking. So this is defined as the recruitment, harboring, transportation, provision, or obtaining of a person through the use of force, fraud, or coercion, essentially. So making somebody do something they don't want to do, either by force, threat of violence towards them or to their family member, or some other way of coercing them. A frequent one is getting somebody addicted to drugs and being their supplier of drugs so they never want to leave you and they constantly need you, essentially. Most commonly, this is human trafficking tend to be used for labor or services, specifically like slavery, modern day, like working or commercial sex acts. It happens in Vermont. Now, what I'm showing you here is that this is kind of a list of life behaviors that could lead somebody to being more at risk of being human trafficked, engaging with certain populations. But just because somebody does this does not mean they are actively being humanly trafficked or human trafficked. So it's really just highlighting a unstable home life with not a lot of supervision and lack of education. So you're going to see a lot of like antisocial behavior, hanging out with people who aren't usually associating with, using a new substance or being abused, right? A lot of these different things can lead someone to being human trafficked. Tends to be people who get into these situations are more likely to being trafficked. There's a link for the information about human trafficking in Vermont. I'm going to show you the slides right here, but if you want to look into it a little bit more, here's the breakdown. So total contacts since 2007, there's been around 400 reports of human trafficking in Vermont, and total actual cases were 83 with total victims of 39. So 39 people were really human trafficked in Vermont since 2007. So where's the actual year spread? Oh, that's right here. I have it as 2020. So in 2020, 13 human trafficking cases were reported in Vermont, while 31 contacts with potential victims were had by other enforcement. So as you can see, for the most part, it's sex trafficking that we have going on here. And it's typically young females. Out of the people who were trafficked, it was around 11 females and less than 3 males. Majority of them were over 18. And majority of them are also referred, or I mean, found through services. So like police showing up or somebody reporting the tip. So it does definitely happen in our state. We just want to be aware. So there's the number at the bottom. If you're concerned about human trafficking, you can make a report there. And so again, the difference here is specifically the reason they're being abused. So abuse in general, like sexual or just emotional or physical abuse, that is for somebody to keep control over somebody in their life. So controlling what they do, who they engage with, they really just want you to be subservient to them. And trafficking takes that to another level where they aren't just doing it for their own benefit, psychologically or whatever. They're doing it for money, or they're doing it for a purpose. This person is trafficked by a group of people as sort of a product, right? They are a tool to be used. And that's a little bit different. So when we are talking about human trafficking, if you are engaging with this patient and potentially the trafficker, you're going to see signs of abuse. So you're going to see like a lot of that emotional kind of abuse, like manipulation, like trying to get them to stay out of law enforcement or EMS hands. They might say, treat them right here. They don't need to go to the hospital. Just give them a Band-Aid or whatever. They'll be fine. I'll bring them later. Really doing everything in their power to not get them into your custody, essentially getting them out of their custody. And the patients are just going to be really nervous or really upset around that person. They might not be comfortable. They might be fearing for their safety. So in general, one of the good things that we definitely want to ask any patient that we're considering or suspicious that they've been human trafficked or abused, if we get them out of the earshot of the person we're suspicious of, which we hopefully should do, is we can straight up ask them. It's very easy and revealing to ask your patient, do you feel safe at home? Because if they go, oh yeah, absolutely, you believe them. And if they're like, yes, I do, right? Little responses can give you an indication. If I ask somebody, do you feel safe at home? And they're like, well, yeah, I'm going to report suspected abuse based off of that. Essentially, if I saw things in the home that made me think, you know what, do you feel okay here? And they gave me that response, that's enough for me to be like, oh, there's something else going on here. And if there's not, maybe I'm misreading, but whatever, right? I did my job. Any questions about abuse? Excellent. I was trained in a martial arts studio from the ages of 5 till 18, so I know all about it. But moving on to special health needs. So this is going to include cognitive impairments, communication impairments, sensory impairments. Also, we're going to be talking about use of technology that keep people alive, medical technology, and adaptive equipment, that kind of stuff. So whether or not we're talking about somebody who's deaf, we need to use ASL or a different way of communicating, or somebody who has something like a service animal, right? Those will need to be accommodated. The only time we're really allowed to bring an animal in the back of the ambulance is if it's a service animal. You can definitely transport somebody with one of those. Now, one of the things we're going to talk about is autism. And also we're going to talk about just kind of briefly things like Down syndrome and other cognitive impairments. So these patients, while they will have traditional health emergencies, So allergic reactions, broken bones, anything that really anybody can have, these patients will have. We are going to have to treat them not differently, but we're going to have to approach them differently, right? We're not going to be able to do exactly everything we would standardly do with somebody who doesn't have this type of cognitive impairment, right? So right at the top, you're going to see this slide contradicts each other a little bit. If you've met one person with autism, you've met one person with autism. They can range quite broadly, right? It's a spectrum. And then I say, here are some common traits. So take these with a grain of salt. These are just kind of some of the things that tend to be more common, right? So literal perception of things. So if you're like, hey, I need to take your blood pressure, they might have a reaction of, well, are you going to give it back? If they don't necessarily know what a blood pressure is, right? So saying things like, hey, I'm going to place this cuff on your arm. It's going to squeeze and it's going to let me measure your blood pressure, right? Saying things that are literally what you mean, not kind of what the phrase's vernacular means. Don't try to make like a lot of subtle jokes. They might have a flat personality, so they might be very blunt with you. They might be critical, they might be super honest, and they might have a little concern about social norms or appropriateness. In general, this is tough, especially when it comes to kids. The one time that I'm thinking of is we got called to a kid who had a broken arm and he was severely autistic, like wouldn't make eye contact, would not speak to strangers, and really didn't present that he was in pain. He was with grandma, fell down the night before, got right back up and continued playing. Grandma didn't think anything of it. But the next morning, his arm was down by his side and it was floppy and limp, but he was guarding it. Like he was like hissing and attacking her if she got too close to his arm. So when we showed up, he was running around the house trying to avoid us. The only way I could assess him was probably from about 5 feet back if we were all sitting down on the ground. And from where I could see, his arm was broken. Like he was definitely very swollen. He couldn't move his fingers, or he wasn't moving his fingers, and it was severely broken. We tried for about 45 minutes to an hour to find a way that he would feel comfortable allowing us to splint it, get him into the stretcher on the ambulance. Wouldn't happen. So finally, mom was able to come home and bring him to the hospital that way. Right. So like that's the best we could do. He went to the hospital with an untreated broken arm because we couldn't get him safely into our ambulance. So sometimes you're going to have to think outside of the box like that, get something else to work. And so they might have an unusual response to pain. To me, that kid didn't look like he was in pain unless I was trying to assess his arm. He just wasn't using it. He was going around normally, happily doing everything he usually does, just without his arm. They might have extensive or like severe reactions to, not allergic reactions to Band-Aids, but they might not like something like that being on them. So it's just beneficial to be very explanatory of what you're doing. Tell them literally what you are doing. Do and explain that in advance. Tell them what is going to happen and keep them updated. Really use the family as a good intermediate communicator. If they don't want to communicate with strangers, communicate with the family so that they can relay the information or do the back and forth. Yeah, like Nate is saying, a child with autism that has issues with flashing lights, absolutely, right? That could be a big stimulant effect to them. So turning down the lights, absolutely, we can do that, right? Unless we need to move traffic out of our way, it's not going to be a big deal. So just in general, you're going to have to assess your patient, right? Me telling you all these things are going to give you just a little bit of information about what to do, but you're really going to have to assess your patient, get an idea of what they need from them or their family members, and then react to it that way. Just keep in mind, people with like autism or Down syndrome or other sort of cognitive disability like that, they're going to be sick. They're going to be injured just like anybody else, and we're going to have to treat them just like anybody else. We aren't going to change how we treat people based on what condition they have. We are just going to have to change how we approach them, what words we use, kind of how we go about what we're doing. We can't just brush them off and say it's another patient. We are going to have to think a little bit deeper. So next, we're going to go over some technology dependency, some of which can be intense, usually for the patient, less so for us. But the main ones that we're going to mention, we're going to talk about tracheostomies. We're going to talk about different ports. So whether that is a port into the vascular system, whether it's a port into the intestinals, like to either feed, water, or drain somebody, essentially, to have them relieve themselves, whatever it is, we're going to be talking about it. So the first rule that I have for when there's a call with a lot of technology is don't be overwhelmed. Just whelmed is fine. There will be a lot of ports, cables, tubes, beepings, colors, flashings, everything. It's going to be scary. Particularly for me, there was this one student in Winooski who really bedridden, non-communicative, needs to be fed, needs to be drank like via tubes, needs to pee, poop, all that kind of stuff. We show up, you go into the room and there's just like walls of technology. And I'm like, what? You want me to do what? Like this, you want me to disconnect him from all this stuff to bring him to the hospital? Like, I don't even know where to begin. Okay. So keep your approach simple. We are not treating the technology. We are treating the patient. The technology helps that patient stay alive. And if we have a good understanding of our ABCs, we can do the same thing. We are better than machines, guys. I want you to say it to yourself. And anytime you walk into a room and there's a patient on a ventilator, say, I'm better than you, ventilator. I can do that too. Okay. I am a thinking machine. I can treat your patient just as well as you can. So keep it simple. ABCs, keep that patient alive till they get to the hospital where somebody who knows how to deal with that equipment is. We are treating the patient, not the equipment. If the apnea monitor is beeping and you're called for a patient and you go, oh, let me see. Oh, you know what? Well, it was off. There you go. Turn it on. It's no longer beeping. See you later. And you don't see that the person is asphyxiated in the bed, right? That's your issue. We're not treating the machine. We're treating the patient. Use the family members in this situation. They are going to be the best people to instruct you on what is normal for their patient or their family member, what is normal with the equipment. If they have called you, they likely know exactly what the issue is and why you're going to be there. So listen to them. They will be a big help. Home oxygen, very common one. Also, I just love this picture. That is not oxygen in that tank. It is definitely not. But this is one of those common things that people are dependent on. A lot of people need home oxygen. And a lot of people have really intricate setups of like, I remember I walked into this person's house who had essentially created a track like all throughout their house so that they had a bunch of nasal cannulas plugged together essentially. So they had one oxygen tank like in the backside of their house and they could walk with their nasal cannula and it was like a rail system. So any room that they went into, they could have their nasal cannula with them. It was really cool. And then of course there are the patients who just have like miles and miles of tubing on the floor. So anytime you come in with your stretcher, it all gets wound up in the wheels and it's all really bad. But home oxygen, very common, pretty standard to be in a nasal cannula. If people are going to be on home oxygen all the time, it's usually low doses. If they need high flow, that usually means something's bad. They should probably be in the hospital. If we're seeing home oxygen devices, you're likely going to see boxes like this or a just standard tank like we use with a regulator on it. Some are humidified. So like this one, it puts out humidified oxygen. Otherwise, it usually goes up to only around 8 liters. It doesn't have that full range up to like 25 that our regulators do. So usually just a little bit. And for the most part, they're on a nasal cannula. So again, if we're going to transport somebody on home oxygen who needs oxygen in the ambulance, excuse me, either bring their home nasal cannula with you and leave one at the scene, or leave their home one there and put on a new one for them. Who knows? I would prefer to take their nasal cannula with us and leave them a fresh one, because who knows? Sometimes they've been using that same nasal cannula for a long, long time. So it might just be better to get them a new one and take their old one with them, leave a fresh one for when they get home. Now, use of oxygen can kind of lead us towards like vents and apnea monitors. So what these are used for is when a vent is for somebody who needs ventilation. So the person is usually not conscious. It's usually being ventilated for them. And an apnea monitor is usually when somebody just needs to be, their breathing needs to be monitored 24/7. So are they breathing or are they not? If they're breathing, it all sounds normal. If they're not breathing, it will beep really loudly. So again, the things that we want to know about these is like, how long has that alert been going on for? So we can have a rough idea of how long they've been without oxygen. Otherwise, we are going to take over the roles of that machine. So we're going to be doing our ABCs, bagging them if they need it. Definitely ask the caregiver. And if they need anything on those machines, tell the caregiver to fix that machine. They know what to do. You do not. Okay. And don't try to fix the monitor, fix the patient. Now, one that is pretty important for our purposes is tracheostomies and stomas. So when somebody has an upper airway issue, they can have a port essentially put in right into their trachea below their larynx. And it gets air in and out of their lungs. So plenty of reasons this could happen, whether it's deformity, illness, or disease or injury. But for the most part, it's a very invasive procedure. I've seen it done. They just straight up cut in your throat and they poke a hole in your trachea and they put air into it. So usually people who have trouble speaking with these, they have abilities to, but a lot of times they're unable to. And they are relatively thin tubes with ports, and they do sometimes have the fun issue of clogging. And so like this gentleman is doing, or this person, I should say, in this picture is doing, is suctioning that tracheostomy. We have the capability to do that. We carry these devices. It is in our protocol, right? So this is a sterile procedure. We do have to take some extra steps to suction somebody's tracheostomy. So we're just going to read right off of the protocol here. So the indications is an adult or pediatric patient with an established tracheostomy who is having respiratory distress or that's failing, right? So we're going to consult with the patient's caregivers, see what we can do to help, what usually helps. We're going to assess it, right? Does it look like there's anything that is blocking it that we can see? Does it look like it's kinked? Is there something wrong with it? Can we fix that first? If not, right, we're going to assess their breathing. If they're having signs of respiratory distress, even after we've done something, we're going to give high flow oxygen as best we can. There are masks that do fit right over the tracheostomy, or you can just use an NRB and place it over that hole as best as we can. So we're also going to assist with BVM if necessary. Now, if we believe that there is liquid or mucus or something clogging that port, we can put on our sterile gloves with our sterile catheter, and we can suction it. So we're going to attach this catheter to the suction device. We're going to turn it to no more than 100 millimeters of mercury, and we're going to suction it. You can put down some saline into the tracheostomy, just a couple drops to loosen up any mucus. But then you're going to take your catheter and you're going to insert it and you're going to remove it in a circular motion, essentially. And you're not going to force it in. So if you hit any resistance, don't keep pushing, remove it and try again. Add a little water, but you're going to put it in until it gets to that mark right there, essentially. And then you're going to twist and remove with that suction for no more than the same length of time that we normally would, so more than 15 seconds. And we're going to alternate with bagging the patient if they really need to be suctioned, because really with this patient, they are not getting any air because we are completely sucking air out of their only airway. So we want to suction for no more than 15 seconds, switch to bag, give them some oxygen, and then go back and forth if we need to. Okay, so this is another one of those skills that your service will definitely need to train you on, because they each have different suction catheter kits. Usually they're very similar, pretty much work the same way, but they're going to have to go through the process of putting on the sterile gloves. Very rare that we need to do this. I have never done this. And if somebody has one of these in your area, usually these types of issues, they will communicate to the local ambulance services about. So the one time we did have a patient living in Winooski who had one of these, they communicated to us right away. We're moving into this house. This is the issue. This is why we'll call you. This is what you can do to help. And so then we had a training on it. We went to her a couple times, showed up, did exactly what we were supposed to do from the previous times. Worked great. Now, I can't say that everybody who has one of these is going to be that diligent. But for the most part, if somebody does have one of these conditions, it's usually not uncommon that they're going to reach out to the people around them. I need some water. Give me a sec. So central lines is a port that is put in to get into like an extended stay kind of port. It's like an IV that can live in them for quite a while. So usually we see these in peripheral. They can be femoral, or they can be kind of in the chest. It really differs based off of the patient or why they're getting them. There are things called like fistulas that are good for dialysis that kind of go into somebody's arms. That's a port. There are other catheters that you can see up here where you kind of use it as like an injection bladder. So like you put a needle in and you can inject it into there and then it will go into the body. Otherwise, it might just be a line that's constantly in them connected to their internal system. If they need medications pretty much constantly, or they're going to be going into the hospital like every couple of days for an injection, instead of getting them poked every single time, wasting their veins, they just find one good area, leave it right there for as long as they need. We are never going to have really any say with these, not within our scope of practice, not within mine as an advanced EMT. It's paramedic and up. They're the ones who are trained to use these ports. For the most part, though, what we're going to be doing is assessing their ability. So if you look at one and it looks gross and infected and like clogged, that could be a potential for something. We're never going to flush them out or put anything into them, but we do want to keep assessing them for signs of infection. They are a potential for somebody to get worse infection, like moving on to sepsis territories. So when somebody has really bad kidneys, they need to go to dialysis, which is essentially an external process of filtering their blood and putting it back in. So they might get something like this, which essentially is just a really easy port way for them to get attached to the dialysis machine, or they're going to get something like that fistula, which is essentially just a big port put into their arm. Now, if somebody does have a fistula and they tell you we can't take a blood pressure on that arm, we don't want to damage that port, so just take it on the other arm. They shouldn't have fistulas on both sides. Feeding tubes. These are just ports essentially right into the abdomen, directly into the stomach. So if somebody needs liquid food, that's how they get it. There was another student that I worked with at the high school who needed to be fed through this tube and then also get gastronomy water. So water put into his stomach very similarly. So good news is these are relatively safe. If they've got good care, right, it shouldn't be a big issue. Just so you're aware, it is relatively normal for there to be a little bit of like secretions around it because it's going into like the GI tract, into the stomach. It's pretty natural. It's if it starts to be pussy and you see like that redness around the area, that's when we'd start to worry about infection. But if it's a little bit moist, keep in mind that's relatively normal. There is liquids going in and out of it pretty consistently. Okay, so it's less about the port itself. It's more about the skin around the port and how the patient is exhibiting. If they're exhibiting signs and symptoms of having an infection and they have a bunch of these ports, you can likely assume that it's going to be one of these ports or something internal that we can't see. Reasons for placement is really just going to be either deformities that they're born with, or after an injury, which renders them unable to either chew or, masticate food, swallow food normally. So it's going to be really as needed. So you're likely not going to see these commonly. And if you do, it's probably going to be on a younger patient or somebody who has been paralyzed or put into a really bad situation after an accident. Along with food, we need to excrete. So other common things you're going to see are colostomy bags. So this is a port from somebody's intestines right to a bag. So if they need to defecate and they can't do it naturally, the poop goes into this bag and it will build up and you will see it all. It will be right there for you to pick up and bring with you because it is attached right to them. This is also, these are used majority for like extensive Crohn's disease, ulcerative colitis, if they got colon cancer or severe diverticulitis, that kind of stuff. If they're not able to, excrete normally, that's how they do it. Now, the good thing about, for our purposes, about colostomy bags and urinary bags is that they are great for assessment. Is we can get an idea of what their bowel movements and what their urination looks like without actually having to watch them go to the bathroom. So, right, if we're worried about signs of a bowel bleed or GI bleed, we can look at their colostomy bag. If we see bright red blood, bad sign, tells us they've got a lower GI bleed. If we see coffee grounds, right, bad sign, they've got an upper GI bleed. Is it all water? Is it solid? Is there different colors in it, right? That's all good assessment. Something is going on. For the most part, though, we just want to bring these with us. Again, we are not really allowed to do anything about connecting or disconnecting. We're not even really allowed to empty these type of things. So we're just going to bring them with us. The stretcher, most of the bags have like built on hangers, so you can hang them right on the side of the stretcher. And we just want to be careful with them too, because we don't want to forget, leave it on the stretcher and try to pull the patient across and have it get pulled out. That would be really bad. So just keep in mind, once they've got one of these bags, it is a part of the patient. You're going to have to carry it. So similar thing, a urinary bag. So essentially a catheter. There are a couple different types of catheters, but pretty much the most common type is the Foley cath, which is a tube essentially with a little balloon on the end that gets fed up the urethra. Picture that. And then the balloon is inflated. And so then anytime that somebody empties their bowel, it kind of just happens naturally. The urine will flow right out into the bag, and then we kind of move on. So there are other kinds is, again, Foley, most common, but there are like topical ones, essentially like cups that you can put over the person's genitals to catch the urine. But for the most part, if somebody needs a constant cath, they're going to get something like this. One of my first calls as an EMT, we went to a person who I would get very familiar with over my time. He was a paraplegic. And so he essentially could only use his arms. And he had a lot of issues. Went to him for a couple times for an overdose, but one of the first times I went to him, we got called for a quote unquote catheter issue. So we're like, okay, what does this mean? And we show up, he's waiting for us at the door, and he didn't really want to speak to us at first, but when we got into the elevator, he's like, all right, guys, I'm going to level with you. I fell out of bed this morning and my catheter stayed on my bed and it's ripped. We're like, you ripped your catheter, so you need it to be replaced. We'll get you a new bag. Oh, totally fine. He's like, no, not my catheter, my penis, it's ripped in half. And we were like, oh boy. And my crew chief was like, is it bleeding? And the guy said, no, not really. It's not bleeding at all. We were like, great. So we're going to let the doctors assess that. We're so sorry. You're probably glad, unfortunately, that you can't feel down there at the moment. We'll bring you to the hospital. It'll be taken care of. So yeah, just keep that in mind. That could happen. All right. And the last bit here, another population that we're going to see pretty frequently is people who have no fixed abode. I have to change that because we are no longer able to or allowed to refer to somebody as homeless unless they tell us that they do not have a home. Otherwise, we have to say that they are suspected no fixed abode. We can't just say that person is homeless because that is turned, unfortunately, into an assumption by people who either look dirty or unkempt or who just don't live in a great place. I'm sure that if I didn't shower for a couple of days, lived outside, went camping, came back in, you might say, wow, look at that homeless guy with the really long hair and the scraggly beard, right? So we can't just assume. This is a growing population across our country. There's a really big issue, even in Vermont. The poverty line in Vermont is if two people together make less than $18,000, pretty big. At the time of this, I didn't put it on here, but I was looking up roughly what it costs to live in a one-bedroom apartment in Burlington. It was about $19,000 a year. So, a lot of people are edging on that poverty line. So those are some of the big factors that lead to large populations of no fixed abode patients. Lack of affordable housing, high underemployment or unemployment rates, high mental illness, high substance abuse rates, forced evictions really increase on this. Domestic violence increases on this. People who do not have a place to go but cannot stay with their abuser. And then people who've been in prison for a long period of time, getting out, not having a place to go, not knowing where to go, especially if they've been in prison for quite a long time. So patients,
what are we asking them in terms of whether they're homeless or not? If we're not saying homeless, what do we say to them?
so
in terms
we are going to ask them. We do need to get a mailing address a lot of the time, so that I'm never going to make it like a point of my assessment where I'm never going to be like, hey man, are you homeless? I'm going to be like, hey, so we do need a mailing address to get you the appropriate information about this call. Do you have a mailing address you can provide me? If they say no, I am homeless, I'm going to say great, I'm going to mark that down. And so then in my report, I can say the person is self-reported homeless. But the main thing that we're trying to change is that a lot of people were just documenting as this patient was homeless without confirming, right? Just based off of kind of the situation of why we picked them up when plenty of these people have homes. That's just kind of the deal.
Thank you.
Yeah, for sure. So these patients are at increased risk of violence and abuse, illness and disease, and discrimination. Who are these people more at risk of abuse and violence and discrimination from?
Right.
Each other?
No, it's us.
Oh, as
Those
it the
people-
police?
Nope. As in the people who are not in this situation, including EMTs. There are plenty of times where I have been incredibly frustrated dealing with patients who are no fixed abode, based off of how they treated me, but then also a lot of times now me thinking back to it based off of how I saw them. They're not fun patients to be around. A lot of times it's very similar things. It's those overdoses. It's the drunks. It's the people who are calling you because they don't have a primary care provider. Like they're calling you to get a nice warm bed, whatever it is. Like you're going to do that a whole bunch. And that's why. So yeah, they're at risk of abuse from everybody who isn't one of these patients. And it's also one of those other things similar to how we are all one misused opiate prescription away from being an addict. A lot of us are one missed paycheck away from potentially being homeless, right? It's one of those things. It's kind of this up in the air. We are treating them. We're trying to help them, but we can't judge them, and we can't do anything along those lines. And unfortunately, it happens quite frequently from first responders, EMTs, police, firefighter, whatever it is. Health risks, right? Environmental exposure, everything we talked about, cold and heat. If they're outside all year round, they're experiencing it. Lack of medical care or knowledge leads to higher risk of infection, higher risk of letting minor issues become major, and poor nutrition. So again, our job is not to be judgmental. I don't care if you have the nicest house. I don't care where you live. I don't care what you do. If you think you're better than somebody and you're an EMT, you should stop. Okay, you should stop being an EMT. So our treatment's not going to change based off of their living situation. We're going to treat our patients. We can provide education on hygiene and illness. Hey man, you've got this going on. This is what you called us for. I saw your living situation. I know you probably can't change that, but here are some things you can change that might help with this issue. You can provide education on local resources. Hey, COTS is doing this thing. I'm sure you're aware, but there's this place that's open for you and all that kind of stuff. Now, this is just a picture, but this man, definitely not homeless. He's in a house, right? This looks like his house too, based off of the state of it. I don't know what happened, but he looks like he was beaten. And from the image, it looks like that guy is either going for his gun or his handcuffs. So I don't know what happened in this situation, but this is a pretty telltale picture. I've treated this patient. Right, not him exactly, but I have shown up into a house and treated this patient. Does anyone have any questions?